I'm Councillor Martha Vickers, Chair of the committee, and the members of the committee present this afternoon are Councillors Martin Colston. No, we haven't got Billy Drummond. I thought we were going to have Billy Drummond here today. So whether he's coming along a little later. Paul Kander, Alan McCrow, David Marsh, Stephanie Stevenson and Joanne Stewart. Council officers and external partners joining us to advise and support the meeting are Paul Coe, Executive Director, Adult Social Care and Public Health, Matt Pearce, Director of Public Health, and Stephen Bowe, Public Health Consultant, will be joining us soon. For the Thames Valley Integrated Care Board, we have Zoe Woods, Head of Palliative and End-of-Life Care and Community Services, and Section 117, Berkshire West. Dr. Jane Bywater, Consultant in Palliative Medicine, ICB Palliative and End-of-Life Clinical Lead. Okay, this is Matt Pearce and Stephen Bowe, just arriving. And then joining us later, 2:20 for the item on all age continuing care will be Liz Rushton, Head of Delivery Neighbourhood Teams, Diane Utley, Clinical Service Lead, Berkshire West, and Daphne Barnett, Interim Head of Neurotransformation on Complex Cases. And from Berkshire Healthcare NHS Foundation Trust, we have on screen, will be joining us later, Obi Okongwu, Head of Service, Community Nursing and Specialist Services. And from Sue Ryder, we have Louise Lucio, Regional Director of Healthcare Operations, Sue Ryder South East, and Dr. Hannah Weston, Palliative Care Consultant. Gosh, that's a lot. Beautiful. Thank you all for coming today. It's really good that you could make it. Vicky Phoenix is the clerk for the meeting, and Gordon Oliver is the Zoom host. And today's meeting is being live streamed on YouTube, so members of the public are able to follow proceedings. If we hear the fire alarm, we must leave the building immediately via the emergency exits. The assembly point is the Dolphin Car Park, and we follow Gordon or Vicky, basically, or some of you won't know where that is. If the lockdown alarm sounds, we will await instructions from officers. We will adjourn the meeting until such time as it is safe to proceed. Do members have any questions about the way in which the meeting will be conducted before we proceed? Nope. Right, so item 1, apologies. Vicky, do we have any apologies?
Yes, Chairman. We've received apologies from Councillor Owen Jeffrey and Councillor Dennis Bennyworth. We've also received apologies from Councillor Nigel Foote, the Chair of the Health and Wellbeing Board.
Thank you very much, Vicky. Item 2, the minutes. So we have 2 sets of minutes. The minutes of the Health and Adult Social Care Scrutiny Committee held on 14th of May 2026. Can we have a proposer for them to be recorded as a true and correct record of the meeting? Pro? And a seconder? Thank you, Councillor Khan. Of the Health and Adult Social Care Scrutiny Committee held on the 10th of March. Can we have a proposer for those? Councillor Stewart. And a seconder, Councillor McCrow. Thank you very much. Okay, so item 3. Actions from the previous meeting. Oh, sorry. Councillor Stevenson did tell me she had a statement or remark to make connected with the minutes of the 10th of March, connected with the ambulance service.
Yes, please, Madam Chair. Item 7 on that set of minutes was about a South Central ambulance service update. Over the weekend, I received a very bad first-hand report about waiting times for the ambulance service, and I wanted to just report to this committee. I understand a complaint has been made to the council, and that Councillor Heather Codling has picked this up and is following up with the ambulance service. A very elderly resident was badly hurt in a fall. She had a fracture, bruising, broken rib, goodness knows what, but luckily she was found within half an hour. 999 was called and it was agreed that an ambulance would be sent. But after 45 minutes, with the resident still bleeding from her nose, she was taken to the hospital by a friend. 4 hours was the estimate that South Central Ambulance gave as their response time. This is obviously completely unacceptable, and I would be very interested to see what response Councillor Codling gets from her inquiry. Thank you.
Thank you very much, Councillor Stevenson. We will be hearing more about that when Councillor Codling has researched it. So thank you for bringing that up. It's a really important matter. Thank you. Right, item 3. Members are asked to note the progress in relation to the recommendations and actions tracker on page 13. Just to advise the committee that item 3 on that tracker, Children's Mental Health and Emotional Wellbeing Task Group, went to executive on the 28th of May 2026, and the response to each recommendation will be populated on the tracker shortly. At the moment, they're just down as in progress. Okay, and can I also draw your attention to a correction under the response column? It refers to the response from the ICB received on September 26, and in fact it was received September 25. So that was received, obviously, that was incorrect. So just drawing your attention to that inaccuracy. Okay, are there any comments and queries from members in relation to any of the recommendations and actions? No, thank you. So item 4, declarations of interest. Do any members have any declarations of interest relating to the items on the agenda? No, thank you very much. Oh, yes, Councillor Kanda.
I don't have a declaration of interest, but I just wanted to point out that I have to leave just before 4. I was trying to find an appropriate time to say that.
That's fine. Thank you very much for letting us know, Councillor Kanda. So if we're still going after 4 o'clock, then please just leave. Thank you very much for letting us know. Item 5, petitions. Vicky, do we have any petitions?
No petitions have been received, Chairman.
Thank you very much. So we move on to the first main item to be discussed at the committee, which is palliative care and hospice provision. And we have Zoe Woods, Head of Palliative Care and End-of-Life Care Community Services, Dr. Jane Bywater. And for Berkshire Healthcare, do we have Obi Okonowe yet? No, not yet. And also from Sue Ryder, Louise Lucio, and Dr. Hannah Weston. So we have thank you for your report, which is very full and very comprehensive. And thank you very much indeed. So would somebody, I assume just one of you, like to give us a sort of overview for about 10 minutes maximum or something, just to give us your, overview of the whole thing. Thank you very much.
Thank you, Chair. So firstly, again, I'm Zoe. I am all age palliative care. So I cover both the adult side as well as the children and young people. So just to give a start point, the purpose of the report was to provide assurance on the current system approach that we have towards end of life, and set out both where we have started, what we have progressed, and where we think that there are continuing areas of improvement, of which we are working with our colleagues that sit beside me. The key message is that for West Berkshire, we know that in 2023, which is a year that we tend to run a little bit out of sync in terms of real-time data, we do have the figures that in West Berkshire, we had deaths of 1,469, which account for the 1% that we are aware of, which we generally know will die as part of our population. And of that 1%, around 80% of them will require specialist palliative care. The key message that we want to really get across into this, from the report and into this committee, is the function of a more integrated community-focused model of care that we have looked at. And this is driven by individuals who advise the ICB, Sue Ryder and BHFT that their preferred place of care and death would be in their ordinary residence. And therefore, they don't want to die necessarily in a hospital. They would rather die either in a hospice, a care home, or in their own home, which is where we see some of the preferred place of death figures as party to 3.1 on the in the report, page 3. Those are the figures that we know nationally are to be the case. So 37% die in hospital, 28 in their own home, 25 in care homes, 8% in hospice, and 2% in others. We know that there is a demand in increasing the needs around end-of-life care, and we know that the figures of the 1% are likely to increase by 2% by 2040, and these are the national statistics that we understand to be the case. And why that matters is that what we are looking to do in our local area is to ensure that we are holding a sustainable model of care that delivers for the individuals that we are dealing into our services. And what we mean by that is we want to ensure that we have early identification. We want to make sure that we have advanced care plans, or what we know as respect, to be in place. And this is to support the individual's wishes at their end of life and make sure that we are clear on what matters to them. And then also make sure that they have access to services that they require at their most, the time of need. So our assessment at this moment in time is relatively positive, which I hope is noted from the report. We work very closely with our Berkshire healthcare colleagues, so OB has just joined, and our Sue Ryder colleagues. In the January of 25, we did complete a full procurement or an evaluation of a procurement where Sue Ryder were awarded the contract for Berkshire West and South Oxfordshire. And in that, there is a lot of partnership working that reflects the needs of our patients. And so the model of care has changed to benefit the requirements that we know for the patients that we serve. And that's including of a hospice at home provision, an introduction to 24/7 access to a single point of access line, so patients have opportunity to contact the services as well as healthcare professionals. We've expanded our virtual wards, and we also have rapid response. In terms of inpatient units, we have both the Duchess of Kent in Reading, which holds 10 beds, and we also have 8 beds within the West Berkshire Community Hospital that are delivered between BHFT, Royal Berkshire and BHFT to deliver. I'm going to pass over to my colleagues to see if either of them would like to add anything that they think I may have missed from the reporting.
No, thank you. My apologies for, thank you very much. My apologies for joining late. Yeah, all I just wanted to add to this is just recognition of the fact that, you know, like Zoe said, we continue to receive lots of requests for patients to be cared for in their own home. We're aware of some of the constraints in terms of working across organizations, and we continue to make that effort to know our Sue Ryder colleagues and look at how we can make sure there are those seamless transfers of care or support of care for patients in their own home. So even though we've put it across some of the things that we're doing, we're continuing to evolve. We're continuing to look at how we can make it even more better for patients on that pathway. So this is by no means the end of that. It's just the beginning of better working relationships across.
Just to add as well, before Louise comes in, we are fully aware of the complexities and challenges in which we face as well, and we face this across the Thames Valley. And these elements are ensuring coordination, ensuring digital infrastructures are in place for sharing of information, and how we ensure that we deliver a consistent approach to the services that we offer when it comes to access and experience for our patients. And that is identified as a priority within the Thames Valley ICB under a dying well strategy.
So Sue Ryder is the incumbent provider. We were awarded a new contract, a 7-year contract with the possibility to extend for a further 3 years, and it started in January. And the contract includes a new operating model, a new pathway for patients, and that is building, expanding on our community provision. So we know that more patients want to be supported in their own home, wherever that may be. And as part of our new service provision, we've expanded our community nursing service. We've introduced a new hospice at home service so people can be cared for in their homes. Also identifying that we can support people with easy discharge, quicker discharge from hospitals and also from the hospice. And the introduction of a new 24/7 clinical advice line. So that's manned by, held by a clinician, a nurse. And the aim there is for patients and families and healthcare professionals to be able to have access to clinical advice 24/7, with the intention of keeping people in their home, giving them the timely clinical advice when needed, preventing those emergency admissions into hospital. And that's been in place since January, and we're evolving that in partnership with our colleagues, district nursing teams, GPs, and other professionals across the primary care network.
Thank you very much. Thank you for that overview. As I said, it's a really detailed and comprehensive report. And thank you for making the effort to come in person. And it's obvious that you're all working together really, really closely. Before I open the meeting to everybody, actually Fiona's gone. I was going to draw attention to Fiona Warby from Health Watch, who was on the screen and whom I hadn't introduced. She's still there. So apologies, Fiona, for not mentioning you at the start of the meeting. She'll be speaking to her report later on. I just had an inquiry or clarification about the table you've got on page 21. It actually says at the top of the table, preferred place of death. And looking at the previous paragraph, should that be actual place of death rather than preferred? It's just clarification. It looks as though it should be actual. I just wanted to sort that out before we started. It's page 21, and there's a table on the bottom of the page which talks about where people die, and it says preferred rather than actual, but I think it's meant to be actual. Oh, sorry. Okay. You got it too?
So these figures come from the ONS data, and it is preferred place of death. So it isn't necessarily actual, it's just that where they are preferred place of death.
So the other figures are your research, because they don't seem to match up with the figures that you said before about preferred place of death. Okay, right. I think that's okay. Anyway, we'll move on rather than dwelling on that to see whether members have other issues they'd like to raise. So Councillor Kanda.
Hi, the first one is actually related to that, because we talk in 3.1.2 about, not that one, 3.1.4 about public attitudes suggest 56% of people would prefer to die at home. Is that general or is that to our area? Because then it doesn't match up with the table. If it's general and then the table is general, they don't match up. So it's difficult to understand actually then what we're saying.
May I answer? I mean, I think that we know that people don't always achieve their preference, and sometimes that happens for reasons that are outside of their control. It's to do with service access, it's to do sometimes with illness progression, it's sometimes to do with unexpected events. So there is a difference between what people state they would prefer, but also the reality of what then happens. We also know that if somebody is asked in advance about their preference, there is often the situation where their preference may actually change over time. So it can be something that shifts depending on their own personal situation, and very typically about the level of support that they have as a family and the family's ability to support them. So I think there are a number of factors that can influence those figures.
Thank you. I think in general, without being pedantic, it's about we're delivering a service. So first of all, there's a difference in the potentially the service of Berkshire West and West Berkshire, which I don't see a breakdown of that in particular, but that's another matter. But more generally, the service we're providing is we want people, if they're going to die, to have good quality palliative death and be as happy and as comfortable as they can be. So really this is about trying to understand, the reason I was looking at the numbers was, do people want this and end up getting that? And how do we bridge that gap? If there indeed there is a gap and we can plan for it. Because at the end of the day, there's a so what, right? How do we add value to these people who are going to die anyway? That's kind of where I'm coming from.
Just back up, I think you're right. So that I think that 56% comes from a national data set in terms of where people want to die. And I can't see the breakdown for here as to where they actually die. I think, like Dr. Bywood said, there's a huge range of reasons why people don't die where they say they prefer. And one of the questions is when was it they said they preferred to die at home? Because if you ask a well population, a lot of people will say they want to die at home. When you get quite close to death, and people may be more symptomatic and have higher, more complex care needs, and their carers are struggling, they tend to change their mind. And one of the difficult things about this sort of data is, at what point are you looking at, what are you calling their preferred place of death, the one they said then, the one they said now, and so on. So sometimes people don't die in what was named initially as their preferred place of death, but has become their preferred place of death at death. Now you could, or shortly before death, you could argue that that is because perhaps the care at home wasn't what they would have hoped. It wasn't 24-hour care at home, or symptom control wasn't rapid enough, or there may be reasons why something else becomes their preferred place of death. So I think it's usually a mix between people. It's hard to know how you're going to feel until you're in a particular situation, but also the sort of, we're really trying to develop the most responsive, all-encompassing community service we can do, but that isn't necessarily 24-hour immediate everything at home. And sometimes the reality of that then impacts on that person wanting to still stay at home. Not that everybody chooses to stay at home, of course. I mean, the other thing is, if your preference is to die in hospital, but you don't actually need to be there, that can impact on your ability to stay in hospital to die. So there's lots of reasons why people don't stay where they want to die. But the aim with the new services that we've been developing is to make them as responsive in all the different places as possible, to try to enable a higher percentage of people to stay where they want to be earlier on.
Yeah, and that's basically what it's about, right? Because numbers are numbers, right? But at the end of the day, at the point within which we can add value, are we able to? And if we're not, that's what we need to measure and change if we can. That's kind of what I was trying to get out of the report. And I appreciate there's a lot of detail in there and things do change. And maybe that's the journey we go on, which is to try and get to that point.
And it can be really, really difficult to identify data sets that tell you about added value is the other issue, I think. But absolutely, what we want to see is that we add value for those patients.
Thank you very much. Thank you for that question, Councillor Kander. Councillor McCrow?
Thank you. We were sent a report on palliative care in West Berkshire by Marie Curie, and that is quite an alarming report in my view. Headlined, end of life care in the UK is broken. And it also says almost 1 in 3 people who need palliative care are not receiving it, which is pretty awful. And there is a real lack of out-of-hours care in many parts of the country. I think particularly in areas, rural areas like our own. And finally, kind of referring back to what we were discussing before, so in West Berkshire, 44.3% of deaths occur in hospital, compared to 42.8% across England. That's a high number. Not only does it mean that patients are not dying where they would prefer to, but also surely this is putting a strain on our hospital services, tying up beds and resources in hospitals that could be used for more acute cases. Thank you.
So I think there's a couple of things, and Martha, if it's okay, I'd like to just confirm back on and clarify the number. The table on page 3 is actual deaths, not preferred place of death. So just wanted to clarify on that point. We are very much aware of the Marie Curie report, and Jane and I attended the National Summit for Palliative and End of Life Care, I think about 3 weeks ago. Bringing all sort of system leaders, NHS England and Hospice UK and hospices, to sort of come together to understand, well, what does this mean and what does it look like? And in our area, we are clear that we have started a journey, as Dr. Weston has mentioned, in trying to ensure that we have an integrated model that allows for patients to have the opportunity to die in their preferred places. And that's the start point. We have, as a Thames Valley, we have put investment into ensuring that advanced care plans are made accessible via the Thames Valley Shared Care Record, and this is via something called Respect. And that then answers to your question about how do we start to make sure that we capture the unmet needs. And that's the starting point. Against this as well, we are working, we are very much aware that there is a modern service framework that is going to be setting out what is expected for the NHS and ICBs to be delivering. And that should be coming to us in about autumn time, and that will be from Stephen Kinnock has been the person behind making sure that that is something that is out into a deliverable specified area. So this is why the ICB, alongside its system partners, is clear that dying well is a priority. And what we mean by dying well is ensuring that people have proactive care. So, you know, how do we ensure that people are identified as end of life, rather than it becoming very reactive and trying to source care at that very point? It's about trying to put the preventatives in place to stop people from coming into hospital. It's also recognising that there is system complexities against this in terms of the way that the public view palliative and end-of-life care as a societal taboo. And that is something that we are trying to actively address by asking patient participation groups, well, what does dying well mean to you? And making sure that we listen to those areas. I think it is really important as well, and I'll ask Dr. Bywater to talk to this, that in Reading we have set out sort of a pilot of webinar series for a Dying Well Charter, that we've started it in this area because of we could see that a number of palliative and end-of-life patients were ending in an re-enablement pathway, and we were saying that's not appropriate, and so we need to do something different. And so we have spent time and effort to work through what does that mean, and we're hoping to have a Dying Well Charter, which we will then fundamentally want to roll out to the rest of the local authorities and to and work collectively to try and address some of these issues. But I think it's quite important and pertinent to your point.
Thank you. I think it's a real opportunity to think about how we create a place in our communities where we talk more about this. It's very common that actually it's a taboo subject and people don't talk about it, and it often contributes to people feeling very isolated and alone when they're facing the end of their lives. So I think the idea behind the work that we've been doing in Reading has been looking at how can we begin to build a more compassionate community where actually it is talked about, it is acknowledged, people are being able to get the support they need, not just from professionals, but also from the people around them in their local communities. We had a very moving focus group a while ago which Newbury Cancer Care held for us. And one of the points that the people made to us is very typically you think about healthcare professionals as being the workforce, but actually in our experience, we as the relatives were part of that workforce. And often we're the neglected ones, and we're the ones who find that we are left alone, struggling and not getting the support we need. And some of that is that actually society hasn't shifted. We need to talk about this more, and it's a really lovely opportunity that you've given us to come today. And I think what we would really hope to aspire to is to think about how we could work with you to begin to shift that change and begin to have a more open and honest conversation in our local community.
Well, thank you, Dr. Bywater. That, that's something that we could be thinking about, an action that we could be taking as a council, because we're quite a small group of councillors here today. We are live streamed, but we're aware that we know we've got one member of the public that usually tunes in, but we don't think we're extensively looked at. But, that's a really good suggestion. Just before I've got a list of other members who want to ask questions, as you're the GP rep here, one of the things I was going to ask was about GPs training, because obviously you're the access, you're the plate where referrals are made, I'm pretty sure, aren't you, really? Or I suppose it could be community nursing, but so is there training, particularly for GPs and community nurses, to actually, has that increased lately because this is seen as a bigger issue?
From a community nursing perspective, end-of-life training is one of the essential training that we offer to our staff, so they're all well aware. And this is because a lot of the patients do get cared for in their own homes. So we do also have a specialist palliative care nurse who supports the care homes as well. So from a training perspective in the community, we are covered. And I do know that from time to time, GPs offer the opportunity as part of their tips to get a bit of a refresher on palliative care support. The digital respects that was rolled out, there was also training associated with that to get GPs to know how to have a conversation, put patients onto the digital respect so that people can actually see what their wishes are from that support from an end-of-life and palliative care end-of-life pathway.
It's a difficult question before I bring you in, but because of all the discussion we've had about assisted dying, has that sort of muddied the waters? Do people trust what's going to happen to them? I know it sounds a really awkward question, but some people might really have anxiety about what is all this about. So I suppose that's a conversation you have to deal with, I suppose, isn't it?
I think at this moment in time, from an NHS perspective, we're waiting for the policies to land until any further training and education is delivered, can be delivered in and around assisted dying. So we have to wait for Department of Health and Social Care to provide us with the policies and guidance of what we need to work with. But from a hospice perspective, it might be. Yeah. Yes, please.
From a doctor point of view, I can't say, I don't know if Dr. Bywater's had a different experience, that I've had more conversations, but I was expecting a lot more, but surprisingly haven't. It's always been something that certain patients have wanted to talk about, and to understand the purpose of things that we do and the opportunities for assisted suicide and so on. But I don't think those conversations have increased, surprisingly, recently.
I just wanted to say that we have provided our patients with the opportunity to share their opinions and their voice around assisted dying, and we've channeled that to ensure that they are, have an opportunity to be at the table, really. And that otherwise, that's been the basis of our work so far.
Councillor Stevenson.
Yes, thank you, Chair. I've actually got a couple of points, if I may. First of all, I read that community nursing turnover is 11.3%, but it's in line with the turnover across the NHS. However, we're told by the Royal College of Nursing that the demand is expected to rise by 34% over the next 15 years. So limited workforce growth is recognised as a national issue. So what I want to say is that I was really pleased to read how this topic of recruitment and retention is being handled, because it's obviously vital that we have a well-trained, experienced group of staff working in this area. So I just want to say, carry on the way you are, and do please focus, particularly on retention.
Thank you. Thank you for that. I must say that the 11%, we've worked very hard to get to lower that. And historically, there was a time when we really struggled to recruit into the community, especially in West Berkshire area for obvious reasons. But we have continued to look at increasing pathways and opportunities for our community nursing staff. I've come to this meeting with Naomi, who is one of our newest recruits. She's a consultant nurse specialist for community nursing. So we have continued to look at pathways which will keep people interested in working in the community. We've got a really robust induction support for people so they know what to expect. We provide them as much support and as much opportunities to explore how they can be specialists within that generalist field of community nursing. And that has really worked for us. So it's something that we're very proud of, the fact that we're trying to keep and train and keep people in our community teams. So thank you for that.
Can I just
Thank you.
can I just ask something on the back of that, Councillor Stevenson? Is there any way that the council can help as regards recruitment or raising this as a career, possibly through, I don't know, contacts with the college or some, you know, again, it's how we work together, because we need to put it in people's minds that this is a really important and very, you know, essential career.
Absolutely, you can help, because some of the things we tend to do from time to time is to participate in career fairs. And I'm not sure when the next one is, but it's an opportunity to go out into the communities and talk about community nursing, because there's always been this myth that for you to work in the community, you have to work on the wards first. But that's not totally true, because in the community, the patient is totally different. They are the boss in their own homes. You've got to acknowledge that and work with them. And you don't get a lot of the white coat syndrome type things you would get when patients are on the ward. So actually, you do need a slightly different set of skills in order to thrive in the community. So we are keen to, you know, go out, talk about it. We've done school fairs, we've gone to colleges and universities to try and, you know, talk about it and get people onto that pathway. So the next time we're looking at a career fair, definitely we'll come to you and see how, or when you're having any fairs, please let us know so we can come and have a stall so we can talk to people about our pathways.
Thank you. Right. Councillor Stevenson, you have another.
Yes, thank you. My second point was that I read that a strategic shift towards coordinated community-focused palliative care has taken place. And I think that is marvellous, because the aims are to reduce avoidable reliance on hospital-based care. Now, as the partnership with Sue Ryder has only began in January of this year, I'm wondering for us whether it would be something we could aim for to have an update on this approach, say in March of 27, when they've had a good year using this new strategic way of handling things, and perhaps reporting back to us then, if possible.
Thank you. They're nodding, so that's a good suggestion. Thank you, Councillor Stevenson. Did you have any more points? Thank you. Councillor Stewart.
Thank you. I have been very privileged in my career. I've worked for Daisy's Dream, a child bereavement charity, where before I worked for them, I was probably quite scared of talking about death. And children are great levelers. And, you know, they just tell it like it is. And eventually, as an adult, you think, right, okay, if they can do it, I can talk about it. And also, as a council member, I've been able to go into care homes. So I've been able to hear conversations at both ends of the spectrum, I guess you could say, the age spectrum. One of the points I wanted to make was the fact that for some people, a care home becomes their home. And you hope that for everybody that's the case. And certainly the care homes that I've been lucky enough to visit, they do see the staff as their extended family, and they see the room and the environment that they stay in is actually is their home, and that's where they would prefer to die in many cases. One of the things I'm really interested in, because what an interesting time we live in, where we are with neighbourhood health programmes, and also trying to encourage not only ourselves to look after our own health, but also to have choices at end of life, that we might want to do that in our own home. And hospice at home, I'd just like to know a little bit more about that, actually, because in my mind, I'm imagining you might need lots of kit, lots of equipment. I'm trying to think how, my house might need to be adapted to accommodate that. And I know it's quite a challenge for people. So, and I think I might have heard you have the opportunity for some of these. So hospice at home maybe is an opportunity, but actually, what does it entail and is it realistic for everybody?
So we have a range of services for our patients to hopefully keep them in their home, wherever that may be, their place of residence. So first with the community, they would start off with a community nurse specialist who would assess their needs and look at a care plan. And then in terms of looking at keeping them remaining in the home, so we have OTs, so occupational therapists, physiotherapists. We use community equipment, Willbrook, who provide our equipment for our patients in their home, support them with that transition, not only in ensuring that it arrives and they know how to use it and it's safe, but also supporting carers as well to enable them to use that correctly. We have a hospice at home service, so that includes senior healthcare assistants, so almost like a specialist domiciliary care service. So the clinical element is provided by our community nurse specialists and our doctors and our consultants, and then the actual domiciliary care piece is through our hospice at home. And they operate 8 to 8, so 8 in the morning to 8 at night. And then overnight, we then work with partners who are already out in the community, so through Westcorp in terms of those that medical support, but also with our clinical advice line as well, working with other healthcare professionals. So we work in partnership with a range of community services to enable people to stay at home. And then some of that is obviously delivered by ourselves through RIDER, and then others by our community partners.
Thank you. And if you've lived in Reading all your life, everybody knows Sue Ryder.
Yes.
Did you want to?
We'll happily come back to talk about children and young people's palliative care if at any point as we cover both sides.
Thank you very much indeed. Right, Councillor Marsh, waiting patiently. Thank you.
Thank you, Chair. I've got a couple of questions about the role of hospices themselves, one general and one specific to this area. So this may be out of date, but my personal experience was that my mother died at the age of 81 and my wife died at the age of 51, quite close together in terms of, it was about 20 years ago. One went from a hospital to a hospice in Macclesfield in Cheshire. One, my wife went from a home with a Macmillan nurse to a hospice in which you will be aware of in Sydenham in South London. They both absolutely loved the hospice. They sort of seemed to think of it as a holiday and a lovely place to just rest and gradually sort of fade away. The care was unbelievably good. People came, we could come and go whenever we felt like it, and it was just a really happy experience, and it was about as good as you could get. But I get the impression, and you haven't done anything to dissuade me of this, that these hospices have become somewhat unfashionable now, and I just wonder if that's the case, and why? Because is it that they're provided by the voluntary sector and therefore and not by the NHS? I don't know why that should be, but it seems to be. Oh, is it because they're expensive to run? I imagine they are, because they're residential. I mean, I'm not disputing all the many positive things you said about hospice at home and so on, but to me, that's just my experience, was that hospices were great, if you can use that positive expression. And I'd like to know on how you would now say that what their role now is. Do you still feel that for some people it's the right thing and that it is preferable to at home or in some other place? And then could I do my second question after that, because it's slightly different, slightly more detailed about local circumstances? Thank you.
Thank you.
So if I just answer the one bit, and then if Louise comes in on the more specifics about hospices. So in our area, we have 9 hospices in area, and 3 of which are NHS based, meaning that they sit party to our acute. So in Oxford, we have 2 hospices that are party to the NHS contract of OUH, and in Buckinghamshire we also have the same. In our area, we also have the 8 beds at BHFT, so that model is integrated in that space where it's delivered by an NHS provider and with the specialty elements from a hospice perspective. So there is variance in our area against NHS and independent hospices, and we're very lucky to have national hospices and independent hospices within our area as well. And then Louise, if you want to talk about the more specific question.
So hospice has a place in our service delivery. So we have patients who choose to be in a hospice and have other patients that require hospice care where they're to manage their symptoms. We have a 10-bedded hospice in Reading, which is accessible to all of our patients across West Berkshire and South Oxfordshire as well. And then it's also supported by the community hospital beds. In terms of the hospice care, it is a more expensive model. It's 24/7, but that doesn't deter us from providing that in terms of the pathway and the choice of our patients. We have patients who, could be, an example, be in hospital and still require care and support in terms of that symptom management. Their next step would be to the hospice to then progress into the community. So for us, we utilise hospice beds as part of that care that the patient requires. And also some patients choose to be in that hospice. So for us, the feedback from our patients is really it's really high in terms of the experience that our patients and their families have in our hospice. It has a place, and I don't think that's changed. The change we have at the moment is the fact that more and more patients do want to be in their home. So that's the feedback they provided us. That's what their families want. It's not always possible. Where there is a requirement for care and support, we put additional services in there now, working with the ICB. But sometimes that plan does change, as Hannah alluded to earlier, and people do then have to progress into the hospice. We do have some younger patients who are actually being at home around their children when they're at end of life. It isn't actually something that they want to do. They don't want the family home to be that memory where their parent has passed away. So that's just a real example where actually younger people are choosing to go to a hospice as well to, as their last place. Kind of anything you want to add in terms of the patients.
Thanks. I think Louisa said everything pretty much really, but hospices are absolutely still have an essential place in the whole palliative care pathway, and all the services that should be provided. And absolutely sometimes people come in because that's where they choose to be. I think before there was a gap where it could be quite difficult to choose to stay at home, particularly if you lived alone, for instance, if you needed quite a high level of care. Because so I think the focus on the community has been around meeting that gap. And that's often the gap that you see nationally more than hospices have been provided for a while, whereas the community service has been very patchy, rather than hospices not being still part of the model. So for us, it's a really essential and important part of the model. So we have 10 hospice beds, and then across our whole patch, we've got another 10 beds in community hospital, including the 8 in West Berks. The hospice ones are the ones where there's 24/7 on-site doctor cover if needed. And so we have our most, in terms of any patient can choose to be there, but we also have our most complex symptom control patients there. So if you have complex pain, need complex medication and so on, the hospice is the right place for those people to be. And so again, it's an absolutely essential part of our provision for our patients.
Thank you. Councillor Marsh.
Thank you, that's very helpful. Just briefly, so the planning application for various things, houses, a supermarket, a care home and a hospice was granted by West Berkshire Council, and it's a 20-bed hospice in my ward at Saddleford, just next to Newbury College. And I'm just wondering if variously in this process, which has gone on for a couple of years, I've been told things like it will never happen because it's not needed. We don't need a 20-bed hospice in Newbury. I've been told it'll never happen because nobody wants to take it on and run it. I've been told it is going to happen and it's very important and this is a crucial part of the application. And I can't find out exactly what the status of this is. And I just wondered if you know, and if this actually is a live thing that is being proposed, or if it's just something that they added to the development that is never actually likely to come to fruition because it was probably about 5 years ago, the application was first, and demand attitudes, as we've been hearing, needs may have changed since then. Thank you.
So we had the planning application come through to the then Bob ICB, and we shared that with our Sue Ryder colleagues and our BHFT colleagues. I would question, and I think we're in agreement with this, is we're not sure whether or not a 20-bedded inpatient unit in this area is really what's needed. Particularly as we have 18 beds across the Berkshire West piece, which for a population of our size in its totality, that's about the right numbers. And that is the same then when you're looking at expanding out the fact that more patients want to die at home. You look at that sort of demand and capacity and want to make sure that we are sustainably putting forward the service provisions that meet the needs of the patients that we follow. So I think that if we were to have a 20-bed hospice, as far as my understanding went from an ICB, it went back and the outcome was rejected. However, as far as I'm concerned sitting here today, I'm not 100% sure that it would be entirely needed for our area, because we have very good coverage as to our palliative and end-of-life patients as of today. And we've looked at that model, haven't we? And we've worked through that space as to whether or not we think it is the right model of care and choice. But I don't know if, Obi, there's anything. Yeah, so I think we're all in agreement.
Okay, thank you for that, Councillor Marsh. And Councillor Colston?
Thank you. Yeah, just quick question. You say that, we're moving probably to more people wanting to die at home. Where do you expect that to go, and have you got the capacity to support that change?
So I think that's the areas that we're looking at, and we're recognising that the increase is expected to double, and so it's why the ICB is working with the system partners to look at dying well, and within that will incorporate an area around access so that we can ensure that we are able to meet the needs across fundamentally not just the hospice, it's also our community nursing, it's also GPs, it's also social care, and it's also our scouts as well into that conversation. So I think that's the direction of travel in which we want to move in, and that's in line then with the road to recovery mandate set out by for the ICBs to deliver against in the 3 shifts in our 10-year plan.
Thank you, Councillor Colston. I was just going to raise the issue about dementia. I mean, obviously, in your tables, I think, I'm thinking going forward with public health and more education, hopefully maybe the numbers dying from cancer might reduce, as people become a bit clever. We've got our public health lead over there. But obviously, with our ageing population, dementia is going to go up. And there are ways of hopefully trying to stave this off, but it seems to be like a steady climb. And how are you preparing to sort of deal with that? Because in your report, it sounds much more complicated, because the progress of dementia, when do you get to the stage where you're preparing for end of life? Because it's so, well, I don't know a lot about dementia, but I wonder how you're preparing for that. And also just to comment about Sue Ryder and the fact that you have to, is it 50% of your funds you've got to raise yourself through charitable? Is that sustainable? You're doing vital work, and I don't know where we go with that, and whether we can, whether council can help in any way, or, any of those issues. Thank you.
So if I talk a little bit about the dementia bit, feel free to come in if there's anything else to say. So I think the first thing is that obviously the general approach to community and to the whole system in terms of palliative care is really important, and the integration into hospitals, the working alongside the community nursing team and providing shared care to dementia patients is often the really important thing. It's not necessarily that they have really complex symptoms, but the care that they need is widespread and complex. And they usually need it from multiple different providers. So really working on integrating our service alongside all the other services that they're likely to access is one of the important things. And as part of that, looking at joint clinics with other providers, joining frailty hubs, looking at working alongside the integrated neighbourhood teams, and those sorts of things are the really important thing for us to do. So the complexity of the specialist bit of palliative care is not high, but the care they need is complex. And so I think from my point of view, the really important thing about us being ready to help deal with that is to be working really closely and well aligned with all our partner providers in the area and have our whole system up and running well as quickly as possible. Yeah.
Did you want to say something?
Thank you. I mean, one of the things that we're wanting to do is to think about frailty, which is a very an important area of focus, particularly in primary care. And what we know is that people, as their dementia advances, become very frail. And one of the things that we know is that if you have advanced frailty, then you are very likely to be in the last year of your life. And therefore, there is an opportunity to try and pull together those two strands of work, to think about how we can integrate preparing people for the end of their lives in thinking about people who have advanced frailty, and that would capture a very substantial amount of the patients with dementia. I think it's an important area, and it's right that we should look at it. They don't necessarily fall into nice categories where they have a preference about their care, but yet, as Hannah's touched on, their care needs are very high. So I think our aspiration is to look at this within the realm of frailty and see how we can begin to pull those two elements together.
Yes, I would agree very much with what they have said. From a community perspective, patients who have dementia will fall within our complex patients. And what we tend to offer as part of their support is to look overall at the frailty needs, taking into account in end-of-life conversations, bringing them forward for multidisciplinary team conversations to make sure that not just their health needs are addressed, but also looking at some of the social elements as well, looking at working with our VCSE partners, which we've got good relationships with, to try and see how we can provide a well-rounded support for them on that journey. And again, it's recognizing that when you are really, really frail, we have to start having those conversations, especially when you've got dementia, having conversations with the family and making sure that the support for you is really well-rounded at that last phase of life. So it's something that we do recognize and try to get that support early on. So.
Thank you.
I think some of this is really important when we're talking about early identification and making sure that people have care planning. And it's why it's one of those fundamental areas that nationally we're trying to look at, as well as locally, is how can we identify people in a more forward planning perspective, as opposed to them being sort of in that palliative and end of life. Because it makes a little bit more sense if we have these conversations when we have our full capacity and are able to articulate our needs and work that way. So it's why we've spent quite a lot of time and investment into respect being the document of choice, so that people's wishes and what matters most to them can be documented at an earlier point.
Thank you. Did you want to make a comment?
Just on the funding and sustainability question, actually. So we've entered into a new partnership with the ICB, a 7+3 year contract, which for us, that is quite unique in some areas, an ICB contracting for that period of time. It means that we've been able to develop a partnership where we can plan for the future. And we receive around 43% of our funding from the ICB. And the rest of that has been made up of either charitable fundraising. We have a large retail network of over 400 shops across the country, as well as a network of fundraisers as well. And then we have other income streams, so sponsorships, grants, and then we also access continued healthcare funding for our hospice at home service. So we have a range of income streams which support us. The charity has agreed to go into a 10-year partnership with the ICB, with the idea that, yes, we will also contribute to the funding. We believe in our cause, and we're also nationally contributing towards the development of the modern service framework and influencing government around sustainable funding as well, and what that could look like. So there's a range of things that we're doing, as well as on the ground around looking at introducing new digital technology to support us and enable our clinicians to do clinical work, free up time to then obviously reinvest into our patients as well. There is a growing need obviously in the area in terms of patient numbers. In Newbury alone, in the last 3 years, year on year, we've seen a 2.5% increase in the number of patients coming from Newbury who require our specialist care and support. So for us, we are looking to the future, looking at how we can enable our clinicians, but also as a product of that, releasing more time to reinvest back into patient care. Anything else?
Thank you. Yes.
I know I keep referencing it, but the point of the ICB's change into having a priority area of dying well also means that we can look at commissioning our hospices and our community services in a different way. We know that if we look at the country nationally, Hospice UK, I think, quotes a figure that our charity funding is about 25% for adult hospices and around 11 to 20% when it comes to children's hospices. So we are very aware of the variation in terms of its commissioning, and it's something that the ICB have at the forefront of their agenda moving forward.
Thank you very much. Members, do you have any more questions or comments? No. Well, thank you. That was very comprehensive and very, very informative. And I certainly look forward to an update. Did you say 6 months? But we can discuss that to see how the partnership is working. And also more on children's palliative care, and maybe Dr. Bywater's suggestion of how we can work together to increase the conversation about end-of-life care. So hopefully we can work together on that. So thank you again. Thank you very much. You're welcome to stay, but I'm sure you've got stuff you need to do. So thank you very much. We'll
Thank
see
you very
again.
much.
Thank you. And thank you, members, for your questions. So we'll move on to item 7, which is health and wellbeing in all policies. An update on this from Matt Pearce, our Director of Public Health, and Stephen Bow, our public health consultant. Obviously, this is an extremely important subject and again involves partnership working. So we'll hear a bit about the paper before we discuss it.
Thank you very much, Chair. I'm just going to assume that the paper's read. I'll just take you through some of the key points. I've got a presentation to support with that, so hopefully that will be helpful. So before I start, just to acknowledge thanks to Officers Chinadu Okoronkwo and Catherine Greaves for their work on the paper, which has been really helpful. So this report in front of you summarises, firstly, the shared understanding of what a high-up approach is in the programme in West Berkshire, the current case for having a health and all policies approach, the progress made in the first 2 phases of the programme, and the impact of the projects that have been supported to date, and the programme plan going forward. So just to recap about what we mean when we're talking about health and all policies. So it's not a service, it's an approach or a programme. So it's not necessarily doing new projects, although that is an aspect of it, and we'll come on to that. But it's particularly sort of recognising the fact that everything that the council does across all its departments has an impact on health and wellbeing in different ways, and for better or worse. And we want to make sure that it's having an impact for better, not worse. And also the recognition that wellbeing is supported by things, not so health is a key part of wellbeing, but also education, the built environment, and all the different aspects that the council works on, and therefore when we're taking decisions on these areas, they may have impacts on health and wellbeing, and that might not always be recognised. So a key thing to remember is that health is not, or people's health as individuals and population. Healthcare is really important, but that's, we think that only accounts for about 20% of health, and all these other things, housing, transport, environment, public safety, etc., which are all council responsibilities, have a huge effect. So health and all policies in West Berkshire, a lot's happened already. So this is just a bit of an outline of where we've started and where we're aiming to go. So at the end of the road is this vision of West Berkshire Council being a public health organisation. I'll talk you through, that's in the paper, and I can briefly touch on what that might mean for us. Not the diagram, no, sorry, this is just a sort of visual representation. So phase one of the programme, which started in 2021, 2022. This was the initial phase that focused on developing the strategic foundations of the programme and securing corporate commitment. So it's where, as a council, we recognise this is something we want to do. It was included in the health and wellbeing strategy. There was an initial pilot project to test that out, and the start to socialise the idea of health and all policies. Phase two, which was starting in 2023, this was the second phase, which was really focusing on developing the tools, the skills, the processes required to operationalise health and all policy. There were two key outputs in 2023-24, which was around a health and all policies leadership workshop for senior leaders and members, facilitated by the local government association, and a systems thinking workshop for the Communities and Wellbeing Directorate, supporting a whole system approach to addressing complex issues. And some of the piece of work that developed after that with health and all policy champions, development of some key tools to support assessing health impacts. We've established the healthy planning protocols that new developments in West Berkshire are that the health impacts of those are considered. Also, we've restructured the public health team to align with other council directorates so we can support colleagues in considering health impacts of their work. This is an outline of the health and all policies projects that were funded through the Health and all Policies Fund, which was utilising some of the public health grant to support work that delivered health outcomes in other parts of the council. So ones are around a parenting coordinator in children's services, work with environmental health around addressing damp and mould, got some work with education and children's services as well. The LIFT platform is the digital support to help people access benefits, and some other work around physical activity for people with learning difficulties. These were the two tools that have been developed as part of the programme. So health impact assessment as a part of decision-making papers. So it sort of prompts officers to consider the health impacts of their work when they're doing new projects or proposals, and it's built into paper templates. And also the sustainability assessment tool, which we worked with the environment delivery team, which is a more in-depth way of looking at the impacts of a project across all the domains of well-being, including environment, education, sort of employment, health, inequalities, and so on. And that's now sort of embedded in council officer assessment of new projects, and all projects over £100,000 have to be assessed with this tool, and we're doing further work on enhancing uptake and the effective use of that tool as well. We're now sort of moving into the embedding stage of the programme. So just to outline the current programme, the goals of that is to move to a business as usual approach. So by the end of this phase, once we've got the tools, the infrastructure, and work around workforce capacity, we'll be hoping that health and policies will just be something we do as a council, and will be business as usual. So it will require a different approach at that stage. We're focusing particularly on looking at measuring the performance and impact of some of those projects that have been funded, embedding health and policies in governance and decision making, and a real focus on these 4 work streams. So first of all, intelligence and evidence and insight. So making sure we've got the knowledge as a council about the population that we're serving, what their needs are, and what their outcomes are, in a way that everyone can access it in a timely way. So decision making can be informed by that data and intelligence, including work around research. We've got a new local authority research practitioner who'll be supporting us to generate new research evidence locally, and also some really exciting cross-council work around developing data analytics led by the corporate team. The skills and development and people work stream is around, once we've got this knowledge, we do have this knowledge, but does everyone know where it is? Do people have the skills to interrogate the intelligence and insights that we have, but also to understand what the potential impacts are? So this is around developing our capacity and workforce. The third around decision making, that's about the tools that I've already alluded to and making sure they're embedded and effective. And the final one is about interventions, implementation, delivery, and again looking if there are more projects that we can sort of seed fund or kickstart across the council. So drawing to a close, the next steps are, as I say, sort of developing the health and policies programme through an organisational change lens, so seeing this as really transforming how we all work, further embedding health and policies into routine decision making, and strengthening alignment with some of the prevention priorities we're doing as part of the GPOR programme, and focusing on demonstrating impact and long-term sustainability. So the recommendations being for Health and Social Care Scrutiny Committee to note the current status and the proposed priorities in phase 3 of the programme. Really invite comments and advice on how we develop and oversee the development of the Health and Wellbeing and Policies programme, and also if there's any further information you'd like, so that you can feel you have assurance about the way that we embed the approach and take the programme forward.
Thank you, Stephen, for that overview. A lot going on there. Councillor Stewart would like to ask a question.
Yes, thank you. Probably a couple of observations as well as a question. I think so. Let's start with training and education in particular. So I can understand, having worked in many organisations, how you become embedded in your own work stream, and suddenly having to think outside of that box and take on something else. For some is a welcome challenge, and for others it might be more difficult. And I would include members in that as well. So I'm pleased to see that you've got mentioned in the report that helping members to understand when we're considering our decisions and having conversations that we also take health into account. One of the things that I remember talking about probably 5-6 years ago now was around planning policy, where sometimes we fall foul of our policies as well as government policies, And in particular, I'm thinking about making healthy food choices when certainly I know of neighbourhoods where I live where actually it's very difficult to make a healthy food choice if you're looking at fast food outlets, for example, or even restaurants. And somebody said to me about, well, you know, you can't stop if somebody wants to put a business in there and they want to have a particular type of food, you can't do anything about it. I think that's one thing that I don't imagine that we have cracked that one yet, but it's certainly one that is always in the back of my mind when we talk about these things. And then I think the list of initiatives are really great if these are some of the things that we're hoping to tackle. I love the idea of the Young Carers Fun and Fit because that tackles so many different aspects, including mental health and well-being as well, which is so important. Will we have or be able to see a sort of a tracker for some of these so that we can see a timeline for when these things will be tackled and also when will we ever know that we're successful, I suppose? The thing with public health is it's one of those things, you might start something now and you're not going to know if you're successful for about 20 years perhaps, or even the full life course. But yes, for these in particular, it'd be nice to see how they develop.
Thank you, Councillor Stewart. Yes, measuring things or something I was going to raise. It's really, really difficult to show what you prevented, isn't it? Yeah. Thank you, Stephen.
Yeah, no, thank you. Really helpful comments. I think you're right around the sort of planning policy. That is an area where we have made progress. We've got that in the local plan now, a requirement to improve health and well-being, but the actual implementation that we still got a bit of work to do to kind of provide guidance to new developers about what we're expecting as part of that. But we are actively working on that, so hopefully we will make progress. Tracking the project is also something we're aiming to do this year. We want to get the balance between these projects are sort of devolved to other parts of the council, so but we want to make sure we've got oversight of how they're progressing. So we've developed now a bit of performance work stream so that we can do that. So hopefully we'll be able to provide that in due course, if that'd be helpful.
Thank you very much. Councillor Stevenson.
Yes, thank you, Chair. I've got a couple of really practical questions, if I may. I found an item that talks of enhanced environmental interventions in homes with damp and mould. And we're going to hopefully invest in new measuring equipment because my experience of checking a resident's flat a couple of years ago now for damp and mould, I went with a specialist officer from Bracknell, was that we appeared to have outdated measuring equipment, or rather not the latest, because the resident then insisted on getting a private company in with better measuring equipment to prove his point. So I wondered if we are going to invest in the latest technology, because damp and mould is really topical.
Thank you.
Thank you, Councillor Stevenson. I must admit I'm not an expert in the specific area, and this is being led by environmental health. My understanding is that as a key part of the project, but I certainly can seek further information if that would be of interest around the, if it's the cutting edge technology that you're referring to.
Thank you very much. And my second one is another very practical thing. You've got funding for a new public health planning liaison officer post, and you're recruiting someone for a 2-year fixed term. So my question is, I'm not sure how this officer will be deployed. Can they actually see every planning application, or how would those applications that might not support healthier, more sustainable communities be brought to that person's attention? And my particular concern would be houses of multiple occupancy, for example. Now, there is one answer in the paper that the new post will include reviewing and responding to the health impact assessments. They're required of new developments, but I'm asking about older houses.
So no, you're quite right. So there is, I think that's the area we need to move into, because we're starting off with work around the new developments. But as you say, that only affects anything that's new that's being developed. as you say, health and impact assessments, that will be the focus, or that is the reason we got that officer in, and they do sort of actively review all those new health impact assessments. But we're also, that officer will be doing work looking more broadly around planning policy, and there is, as you say, I think a gap around what we can do. We are doing some interesting work. Sorry, it's not in the paper, but we are doing some collaborative work with Reading University to explore what the levers that are available to us from a legal or kind of policy perspective at a local level to influence other aspects. And that's one of the kind of key questions that we're looking at, because we've got the expertise in planning, we've got the expertise in public health. They know the planning rules and area, we know the health bits, but it's where we bring that together and get that mutual kind of enrichment that is the real opportunity, I think.
Thank you.
Yeah, it's just to echo Stephen's point. So a lot around health impact assessments, you're absolutely right. It's always looking forward and new developments, retrospectively applying health impact assessments. I'm not sure what work's going on across the country in that space, but I think it's really important. And like Stephen said, it's kind of understanding what levers we can draw on. I think with all this health in all policies work, as Stephen was just alluding to, it is about bringing these professional disciplines together. So having a planner in public health for 2 days a week, you're bringing two different languages, two different professions coming together and understanding. And obviously public health came from planning, you know, you look at sewage works and all those things from all those years ago. That was, you know, where public health came from. So it's like a lot of these things, it's kind of learning from each other, understanding how we all work and how health, you know, can really influence some of those decisions making. One of the visions I've always had is to get people to think like a public health person. So they think in that methodical way, they think about the evidence base, they think about the data to understand how we can really make a big impact. But I think retrospectively, particularly when you think about the wards that are more deprived, that's where it becomes more challenging, because, you know, they're not necessarily going to build new houses in those areas, or they might do, but how they then connect to those old housing places too.
Thank you for that. Yeah, I mean, is that related to that one, is it? I was just going to comment on the planning one. I'm not, some of us actually served on the Health in Planning Task Group, can't remember its full title. So, which was really interesting, and which just showed the sort of how important being the awareness of health was when you're discussing planning. And I think members who are on planning, and I don't actually do planning, are made aware of these issues at the start. So obviously looking at green spaces and various things. I don't know, and obviously what control they have over the types of buildings that we have. Because I was going to ask in relation to the work on damping houses, that actually with it, or climate change happening now, there is a big issue about overheating, particularly if we're building flats and if we're converting what were previously offices into housing. That must be unbearable, actually, living in places such as that. And is that something? I mean, I know mould is an issue, but it's sort of like I'm feeling that's slightly dated. Should we not be looking at overheating and and if you've got, you know, masses of glasses somewhere, how are you insulated?
Yeah, I mean, it's all those kind of things. So a health impact assessment, for those of you who aren't familiar, there's various different tools that exist across the country, but it assesses things like connectivity in terms of active travel, access to green space, allotments, garden size, you know, number of trees, all kind of things, insulation. So there's a set of criteria that developers are required to do. What we need to make sure is they're not just ticking their homework. We actually need to validate those health impact assessments, really making sure we're developing healthy environments. So my assumption is that will be part of the health impact assessment. The other thing we're thinking about, and Stephen might know the detail, is the threshold to which we review health impact assessments, because there's a lot of new developments going up at the moment. And for every new house, if we did a health impact assessment, that's a lot of reviewing for us to do. So I'm not sure we've agreed a threshold yet, whether it's 20 houses, 50 houses, in terms of when we require developers to do health impact assessments. But the National Planning Policy Framework is really going in this direction now, so that's kind of what guides housing developments. And even Councillor Stewart, on your point, they're talking about how we can strengthen the evidence to restrict fast food outlets near schools and things like that. So national policy is starting to catch up a little bit, but we can still do lots of work ourselves in terms of shaping those local environments.
Right, thank you. Councillor Kander.
Thank you. So, yeah, just a couple of points, I guess. Building on Councillor Stewart's comments about tracking, it's also about what does success look like? Because it's one thing saying we should do this. Oh, yes, we've achieved it. Okay, so what, really? And then back to Councillor Vickers, or the Chair's question with regards to homes and damp. Identifying homes that are damp, then what? What powers or what is the plan beyond identification to do something with it or to help from that perspective? It's kind of, I know it's a journey and it's a bit like Kaizen and quality and what have you, you know, it's like putting in a process and then it becomes second nature and it's a cultural shift. I get that. But it also has to deliver something and some benefit to our customers, people, constituents, whatever you care to call them, right? It's like the end user of our services. What is it? How does it impact them? Yes, you've got damp. Okay, now what? That's kind of where I'm coming from.
Yeah, I mean, I think, you know, we get challenged, our chief executives over there as well. And I think, you know, we get challenged on that question all the time that, you know, this is the right thing to do. You know, it makes sense to do it. It's how do we bring it to life? How do we move it beyond this kind of theoretical concept that we all think is the right thing to do to track and monitor impact? Some of that is really hard. Some of it is quite soft influence. So even just the conversation happening, you know, in the room where somebody's suddenly talking about health inequalities. If I hear somebody talking about health inequalities, that I kind of feel like my job is being accomplished, but that's really hard to measure and monitor that. So I think we've got some work to do to really come up with a bit of an outcomes framework. For all those individual projects that Stephen mentioned, we have specific metrics. So we are giving public health grant for that project, damp and mould, and there are metrics that they need to deliver to do that. Some of the things that we're trying to do is connect that to primary care data. So when people are coming forward with respiratory issues and conditions, we can track that back to housing and you can make those connections as well. So it's getting the NHS, I know they're quite keen on damp and mould as well, because it's very, there's a lot of national interest in how, because of the Arab law and things like that. So I don't think we're there yet, and I'll be honest with that. But I think hopefully next time we come back, we can kind of come up with a framework and some outcomes in terms of these are the things we think we will see as a result of some of those interventions.
I mean, I think it's definitely the right thing to do. It's just about how do we make it qualitative, really.
Important, because it sort of shows how you're going, doesn't it? And Councillor McCrory's got a question. Can I just ask about the low-income family tracker? How does that work? Where do you get your data from? I mean, I'm not quite sure.
Yeah, because I just had some data come through this morning. So I don't exactly know how we get the data, but I know we've actually got some outcomes data coming through where they're identifying people that are eligible for benefits that haven't previously been in receipt of those benefits, and we've identified and signposted to them, and then they're now in receipt of benefits. In terms of where the data comes from, admittedly, I don't have the answers to hand. I know we've made some good progress in terms of the Healthy Start. I know I've brought that issue here to this committee before in my Best Start in Life. So we've actually seen, I think it was probably, actually I don't want to quote any figures, I'm probably not 100% sure on, but we've definitely increased access to Healthy Start and more people are receiving Healthy Start vouchers. So these are people, pregnant women or recently given birth, in terms of vouchers for nutrition and vitamins and things like that. But yeah, apologies, I don't know the exact answers to that question.
Thank you. Councillor McCrory.
Thank you. First of all, a simple one on, there's a page 52. There's talks about the remit of the new GPAW Prevention Board. I wondered what this acronym meant, please. The other thing is going back to the interface with the planning team, etc. I would suggest that maybe just rather than just look at the number of new dwellings as a threshold, perhaps we ought to look at the type of development as well. So someone's already mentioned houses of multiple occupation. I think that would be a key one to look at. But also things like converted flats and so on, where you know the places weren't designed to be lived in, so they're liable to cause all kinds of issues, I think. And finally, going back to Councillor Stewart's issue with fast food outlets, we had an application in the Field Village Centre, and we, with the planning committee, were told couldn't resist it on the grounds that there were too many fast food outlets already in the area because we are more than a certain distance from the local schools. The fact that the kind of a very large proportion of the local secondary school walk past that site every day on the way to and from school didn't seem to come into it. So maybe as we move into the new local plan, maybe that's something we look at, whether we have our own local policy. Thank you.
Thank you, Councillor McCrae. Any comment?
Yeah, and there's some good examples across the country, and I'm pretty sure the National Planning Policy Framework is strengthening that. What we need to do in public health is build the case for, because planning inspectors can often throw things out in public health. So we really need to strengthen the evidence base about, we have really good child obesity data now. So we know exactly the number of, we weigh and measure every child aged 5 and 11. So it's how we utilise that data to push back and say, actually, this is not helpful to have this takeaway within that space. But we can certainly do a supplementary planning document on fast food takeaways, for example, which I know many areas have done. In terms of the density of fast food outlets in West Berkshire compared to nationally, we don't actually have an issue. That's not to say, benchmarking doesn't always say that it's good or bad, but some areas, they've got a significantly number of high fast food outlets. Equally, things like gambling outlets as well as another one. Which is getting a lot of national interest.
Thank you, Councillor McCrae. Paul Cale.
If I come back on the GPOR question, that stands for growth, prevention, assets, and we can. Which I'll explain. So the council's got four strands of work, all intended to collectively move us to a more resilient, sustainable financial position. So and I'll repeat those. The we can bit, which is the more oblique one, is about culture, our organisational culture, making sure that we have the right attitude in terms of addressing change and improving our position generally. So growth, building, developing the local market, the economy, etc. Making sure that there's it's a prosperous district. Prevention that's where the greatest kind of crossover with this piece of work arguably sits, because it's about preventing people's reliance on statutory services, preventing them from becoming unwell, preventing them from having poor health outcomes. Assets is about making sure that the council's assets are used to their best effect. And as I say, the final one is about culture, organisational culture.
Thank you.
Paul. Thank you very much. Can I just ask about the Health and All Policies Champions? Is that something that sort of is now in place? And how is that working? I mean, I wasn't really aware that we had champions. I mean, as councillors, shouldn't we really be aware that? So this is certain officers have this role as part of their remit. Shouldn't we be more aware of this championing of these?
Yeah, so that's still in development. So one of the things we want to do is across our service directors is to have a shared level of understanding in terms of what Health in All Policies is all about and what their role might be. So we're scoping out what a short training program might look like for those as champions, so they can understand in terms of where can they find access to data that I just talked about, obesity. What are the things they might want to think about, in their pipeline over the 12 months, that their projects they might be thinking about, where they might want to think about health and policy. So I think that's probably very much in the mobilisation early stages, if you like. We're starting very much at the kind of service director level, but eventually we want to kind of work that through the whole organisation. So again, everybody's thinking about health in all policies, health inequalities in all the work that they do, which is really difficult because they're doing so many other things and it's not always at the forefront of their minds. Just kind of keep reiterating that point. So I think it's very much in the early stages of that programme.
Yeah, but it's good to be aware that that's sort of out there and that we should have that in our minds. You've got some sort of really interesting little projects that you put at the end that your funding has gone into. I don't know how much funding you have, but they're mainly centred on the sort of undeserved, needy community, aren't they? Which is fair enough. But if you're talking about prevention and general stuff that's good for the whole of the community, I've just got a couple of suggestions. One of them was about, which might seem a little bit remote, but it's about sort of like citizenship education in our schools. What we really want is for people to take control of their lives, isn't it? And this starts with young people. So once they know how society works and where they can go if they want help, what their rights are, all these sorts of things, that will make them more sort of powerful in the community and being able to manage their lives better, give them more confidence. So something along the lines of working with schools. I don't know what happens in schools now. Maybe some schools do have such courses. I know there used to be, but just making, because it's a changing world, and young people have got an awful lot of challenges when they leave school, as well as, can we find a job or this sort of thing. So something to make them a little bit more confident and to know how to deal with things, more resilient, I suppose is the word, isn't it? And the other thing was about, we've got some beautiful countryside around here. And I know in the distant past, we had an officer that used to go into schools and teach orienteering to youngsters. I'm sure that hasn't happened for a very long time. But one hears an awful lot about people they don't know how to make their way around the countryside. You can go up and down the canal, which is nice and easy, but sort of an awareness of what's out there and building confidence in how to make your way around it. So mapping skills, orienteering skills, whatever you want to call them. So you can enjoy this beautiful countryside, and it's not just there for, I don't know, for the tiny few. So our countryside needs to be enjoyed by everybody, and at the moment I don't think it is. And what about access to leisure centres? Do we have, do we have sort of passes or reduced entry for people on benefits? Or, is there any way of making exercise more accessible to the broader community?
Yes, a few questions there. I mean, so we do have a Healthy Schools coordinator within the public health team, actually, that they've just, he's actually just changed his role. So just currently out to advert at this moment.
Doesn't have a lot of hours, does he really? No.
So, but I think there's an opportunity there. But, we have the PSHE program within schools as well. So the physical, social health and education, I think that's what it stands for. So it's kind of a mandated element of the school week, which schools have to deliver things like sexual health, healthy eating, emotional well-being, resilience. So there's kind of those things that schools do already. I guess there's probably a role for public health to help support that in terms of what more we can do in that space. A lot of the projects that got put forward was where public health, we had some public health reserves money, and we put a call out for the council to say, these are some of the public health outcomes we want to deliver. What are the ideas out there that other council departments could contribute? So that was how we did that, and there's no reason why we couldn't do that in the future. So ideas are welcome, because we might not have all the solutions. We're not, we're not planners, we're not working education, we're not social care workers. So we welcome ideas and innovation in that space. I think orienteering in schools, it could be something we could explore. My view would be probably work with Get Berkshire Active, for example. So they're the local sports partnership. Pardon? Yeah, all volunteers. So, we do walking programs as well, health walks and things like that. We've got the Ramblers. So, there's lots of things we can do. I guess it's, where do we most focus our efforts and time? And there's a last point I think you mentioned, which I can't remember what it was. Oh, yeah. So I believe my colleague April Pebbody is looking in, because I think they recognise that there's more of an opportunity to get younger people involved in leisure centres. So I think they're looking at how they might be able to do that. Because I think there's a lot of things like gym membership. You have to be 16 before you actually use the equipment. So I think they're seeing, can we kind of reduce that risk and increase access to children and younger people? So I know that's very much in the leisure team's view at the moment. I don't know if any concessionary rates exist. They probably do for young carers, but again, that's probably, I'd have to speak to my colleague about that.
Those on benefits or not?
Yeah, there's definitely concessionary rates, I think, for those on benefits. But again, I'd have to go back to you with the detail. Yeah.
All right. Thank you.
Thanks, Joe. You asked, just back through to you, you asked a question about citizenship as well. So some of our secondary schools do the GCSE citizenship studies. And here at the council last summer, we hosted a number of students doing their year 10 citizenship studies here in the council chamber, sort of setting out some of the work the council does, and we've got some more coming in next month as well. So that is part of the curriculum for a number of secondary schools here and in the country.
Thank you for that, Joseph. That's useful information. Thank you very much. Any more questions or comments from members? No? Right. Thank you for that, Matt and Stephen. And I'm sure we'll be hearing much more in the future. So thanks very much for coming here and for enlightening us. Thank you. Right. Right. Item 8 is all age continuing on complex care. Is she around? Is there? Okay. And we've got Liz Rushton, Head of Delivery Neighbourhood Teams, all age continuing care. Diana, clinical service team, and Daphne, interim head of neurotransformation and complex care. And you're all on the screen. Yeah. Thank you very much. Does somebody wish to give an overview of the paper we've received?
Yeah, good afternoon, Chair. Daphne Barnett speaking. I've presented on the sort of previous 2 or 3 occasions, so I'm going to start with the presentation of the slides. Can everybody hear me okay? Because the sound's very low for me.
No, you're very clear. Yes,
Very
we can hear you
clear.
very clearly. Thank you.
Excellent. Okay, thank you. So obviously just confirming that everybody has received the slide pack and they've been able to work their way through that information, because there is quite a lot of information in today's slides. We have managed to achieve the additional data that was asked of us last time, which we've been previously unable to provide, but we have managed to extract that from the data. There's still a caveat around the reliability just at the moment because of the systems merging and the way things are recorded. We've now got a system in process so that everything is recorded in a set format. So it should improve also moving forward. Okay. So the summary of the slides in the beginning on page 2 goes through sort of the basics of the newly established Thames Valley Integrated Care Board, which established on the 1st of the 4th, 2026, which takes the old 3 Bob places of Oxford, Buckinghamshire, Berkshire West, and in addition, we now have East Berkshire come over from the Frimley aspects. So that's the new Thames Valley ICB. And we're all pleased to be working in that new organisation and through all the changes that that's going to bring. The governance, each place is developing its own systems with local authority forums and to improve that communication between health and social care, particularly within the all age continuing care and complex care arena. So we also have been working on looking at the disputes process and how we can work in partnership to help that process so that we don't spend masses of time trying to solve disputes and more about getting things right in the first instance within the process. And then, of course, we have been working towards arranging joint reviews so that when a patient is assessed and reassessed, that we make sure that we're working in partnership with health and social care on those. In the policy, we're obviously getting all our policies in line with the new Thames Valley ICB. So we're looking at doing further work on the draft healthcare contribution policy that we brought in about 18 months ago. That's been operated in a draft format, and we're working within the next few months to review those arrangements, strengthen those arrangements, and make sure that we have a robust way of coming to some joint funding arrangements where there's a gap in commission services, and that we can work jointly to make that more sort of user friendly as well. And that sort of takes us through to the next part, which is the continuing healthcare activity slides. And this is where we've now been able to provide some additional data. So if we look now onto slide number 3, that will take us through the number of standard CHC referrals per 50,000 population. And what that shows us is that in Q4 of 24-25, for the Berkshire West area was running at 10.1%. And a year later, we've now got that figure slowly increased up to 16.75%. So the story is telling us that we're now working more towards the regional average and that is an improved situation for us to be in. We then look at the eligibility, and what that shows was that at the end of Q4 24-25, we was running at 9.7% per 50,000 population. We're now up to 15.1. So again, demonstrating that slow progress in the right direction. Then if we look on slide 4, that will show the fast track data as it's coming through. What we do notice, if you look across the regions, if you look at the Berkshire West and compare that across with Berkshire East, that's fairly comparable sort of numbers. So we're running at, in Q2, which we presented at Christmas, that was 21.4 and it's now 22.2 at Q4. And if you look at the order on the slide, it shows you've got Buckinghamshire, Oxfordshire, Berkshire West, and then East Berkshire. And the gradient is probably as we would expect for the area, given the sizes of those areas. You know, once again, Berkshire East and Berkshire West are fairly comparable population-wise. We feel that the demonstrated slide there shows that it reflects across the Thames Valley ICB population quite fairly distributed. Slide 5, that takes us through the checklists that come in. We had 182 checklists come in. 101 of those were positive and 68 of those were negative. So that's the checklist that comes in to trigger the continuing healthcare process. And then what we know from that was that of those completed processes, there was 96 completed, and there was West Berkshire had 2 eligible, Reading 6 and Wokingham 13. So that was a total of 21 for the area that were eligible of the 96 assessed. And that goes to the higher end of the conversion rate nationally, which is expected. That's 21 to, it's between sort of 19 and 22%. That's running at 21.7. So it's the higher end of the national average that are eligible for CHC, measured against the amount assessed. And then it looks at the funded nursing care eligible, where a person isn't eligible for full funding, but they're either LA funded or self-funded, and they get the funded nursing care contribution, 13 for West Berkshire, 16 for Reading, and 18 for Wokingham, giving a total of 47. With the fast track slide, it shows that there was 160 fast track accepted, and there's a couple of anomalies with Oxford and Hampshire, but these are bordered GPs that may be coming into that council area. They may be living in ordinary residence in Berkshire West, but their GP falls just over the border in either Oxford or Hampshire. And then there was 45 for West Berkshire, 54 for Reading, and 58 for Wokingham. So that sort of goes then to the concluding slide, but I don't know whether the panel would like to have some opportunity for questions at this point, Chair, or whether you want me to continue.
I think you might as well complete your presentation. I think I find it a little bit difficult keeping track of which page we were on here, but I think I've just about got it. But yeah.
Apologies, I should have said the page number as I've gone along. Apologies.
Never mind. Finish your presentation, then we'll see what comments.
Okay. Okay, so we've done, so we're now up to 6. So that now will take us into the future delivery and our key priorities. So we'll be looking, our key priorities are obviously to continue the joint working with the local authorities to better understand referral trends and the needs of the population, to strengthen, assess and provide quality oversight of the work that is undertaken within all age complex and continuing care, and to ensure that there are robust and strong pathways for consistency across all places within the Thames Valley ICB. We are embedding and continue to embed a central operational service where, as I spoke about right at the beginning, we needed all checklists to come into a central point, not into each place. That way, they're received consistently within Thames Valley ICB. They are then considered equitably within Thames Valley ICB, and then that will drive up the consistency in the amount of people that are then progressed on for full process, for continuing healthcare process. Support timely assessments and reviews. So that's making sure that once a positive checklist is received, that the process continues to conclusion within the 28 days, as is stated within the national framework for NHS continuing healthcare and NHS funded nursing care. That's what we're measured against. And to ensure that the timely reviews take place, which that can be a challenge at times, because obviously we have to review 3 months after eligibility and then at least annually. And that at least annually could obviously change depending on the complexity of each case. And then all our performance and benchmarking goes up to NHS England and is then compared nationally with all other places and systems across England. So that I've summarised it quite briefly because obviously there's a lot of information in those slides, but it now might be a good opportunity to ask relevant questions if panel want any clarity or confirmation. And both Liz and myself and Di were here to best answer those questions.
Thank you. Before we move to questions, I'm going to ask Paul Coe, our Executive Director for Adult Social Care and Public Health, to comment. Thank you.
Thank you, Chair. It's good to see you all online. We speak regularly. That's very helpful. I'll make a few broad points, if that's okay. Firstly, thank you to the ICB colleagues for sharing this local authority level data. That's so important, and I know they had to do quite a bit of extra work to turn their reports into this more granular information. Obviously, if that can be baked into their reporting systems, that will be good going forward, because that's what we're interested in seeing. I noted in the presentation there was discussion about the proportionality of Buckinghamshire, Oxfordshire and Berkshire, Western Frimley, but that was per 50k, I think. So I'd slightly challenge that point. One of the things that's positive is that, tell me if anything's changed here, but I think there was, in the formation of the new enlarged Thames Valley ICB, there was an acknowledgement that CHC was going to be a space which was protected essentially in a way that I think gives us some good confidence, which is great to. Sorry, I'm on gold, so I can't be on silent. Hopefully that's not an emergency. I will check in a bit. I'll note the point that, so obviously lots of questions. I don't necessarily want to dive too deep into the data, other than make the point that, quarters do change. We do get variations quarter to quarter, so it's probably in future when we look at this, as I'm sure we will again, if we have a long, full year effect kind of approach rather than just quarter to quarter, because that will give us a better sense of what's really going on. But nonetheless, I think it's helpful. I think it's positive news about the centralisation process, because our agenda has always been to reduce, minimise unwarranted variation. And so centralising the processes, I think, can give us some confidence that that's more likely to happen.
Yeah.
And so broadly to this committee, I'd say one to keep watching, but at the moment I think we can say there's some positive.
So you feel we're moving in the right direction, although there's, yeah.
As I say, acknowledging that one quarter doesn't make a change, a baked-in change, but broadly there are some reasons for some positivity.
So we need to keep an eye on it. So we need to keep, because this is 6 monthly, it comes back to us, doesn't it, really?
Yeah.
So,
And all I would say, and there was, we did speak in preparing the pack for today. I think if we can do a longer period, like 4 quarters is a better way to get a really solid sense of what's actually going on.
Mm-hmm.
do you want to comment on that before we got a question here from a councillor? Do you want to have that question, or do you want to comment now on what Paul said? There's another Paul. I can ask here. No, she's not saying anything. All right, Councillor Kander, you go ahead with your question.
Yeah, thanks for that. And taking Mr. Coe's point in terms of measuring against the quarters, I think part of my questions are around the fact that just looking at 1 quarter doesn't give us a proper snapshot in terms of what the journey is doing. But I have a more specific question, and I hate to do this just because I know I'm a pain in the butt at times, which is if you just look at your slide 3, I'm struggling, having looked at it, to understand some of where the numbers form. So if you look at the narrative on the right-hand side, you can see the reference to 13.6, which appears to be the middle, or the lower of the dark blue lines on the top bar chart. Then it talks about bringing it in line with the 16.75, which I don't see a line for, other than it being in the bar chart below, which is measuring something different. So I guess and then in the second part of the narrative on the right-hand box, the bottom part, it talks about value of 9.7 rising to 12.8. I don't see a line for that or a number for that anywhere on these 2 charts. So really it's a case of, if numbers are important to put in a narrative, where do we show them in the bar charts? And some of the lines in the bar charts don't seem to represent anything. So, and it might be down to what you're actually measuring behind the scenes and how this report is just churned out from a tool, which I know dealing with some Power BI things are, it's like lies, damn lies and statistics, right? So if what we're trying to convey is what we're measuring, how it's improved, which is what I think the narrative is saying, over a period of time, then maybe there's a better way to show it, and that might be over the 4 quarters, showing a before and an after in terms of the bars, and then a line which goes up or down or just shows what the mean is. So it's a stylistic point of view, but for me, looking at a slide, I don't understand it unless I read the narrative, and even then it's a bit confusing. No criticism, no, because I know you're trying to impart a lot of information. I do this day in, day out, and sometimes I have to do a random stream of consciousness. I end up with 100 slides that I boil down to 10 in the end. Thank you.
Thank you, Paul.
Do you wish to comment on that?
I've written down your comments, Paul, and I'll obviously take them back to the data wizards that sort of pull this data together for us. I personally wouldn't be able to comment on those particular sort of lines. I can see there's the reference to the 16 on the bottom, what you pointed out. I get that. But I think anything of any more detail, I can feed back your comments. So next time we can try and get it more representative, if that's okay.
That's fine. And if those guys want to have a chat, I'm perfectly happy to make myself available to explain
Okay.
my issue.
Yeah, that's useful. Thank you.
Thank you very much for that. Thank you. And Councillor McCrow.
Yes, I had similar issues with that particular slide. Going to slide 6, in the top left-hand corner, we've got number of CHE assessments completed by West Berkshire AACC for each local authority. I think that should be Berkshire West. But the other thing is, in the wording below, it says the conversion rate for individuals found eligible for CHE was 21.8%, which is the national average. However, for West Berkshire, it's 2 out of 19, which is 10.5%, which is kind of only about half the national average. I was wondering why that might be, please.
I don't know. Does Liz or Di, do you want to chip in, or do you want me to continue? I feel as though I'm stealing the show a bit. If you want to comment.
I think because we collect our data and we report as you quite rightly say, not West Berkshire, Berkshire West area. So when we look at the conversion rate, it's the conversion rate for the Berkshire West area that compares with the national average, not each local authority area. I take your point. If we were doing it on each local authority area, it would be 10.2%, but we collect our data and we report our data for NHS England on the Berkshire West area. Well, actually, we now report it as Thames Valley, but previously it was the Berkshire West area, which encompasses all 3 local authorities. So across all 3 local authorities across the Berkshire West area, we are at the higher end of the national average, which is 22%.
I understand that, but my concern is that West Berkshire seems to be only half that, and I wonder why that might be.
Yeah, I mean, there are other factors, obviously, to bear in mind. So if you look at Wokingham, for example, I think it has quite a significant more number of care homes, more than the West Berkshire area does. It's got a higher percentage of nursing and dementia care homes. Not to say that everybody who's eligible is in a care home, but obviously when you've got a lot of nursing and dementia type care homes, that's going to mean you're probably more likely to see people coming into assessment. Similarly, I don't know whether you do or you don't, but if you place people out of your area frequently, so if you place into the borders of Wiltshire or Hampshire, those people won't come to us for assessment because the responsibility for assessment is driven by GP registration. So if people aren't GP registered in our area, you may have some people who are out of our area that are being assessed by other areas. And so those people wouldn't come into these figures either.
Thank you. That would, those issues would explain why the number of assessments is so much lower, but it doesn't really explain why the number of assessments found eligible is so much lower.
Yes.
Yeah.
I'll just go back to the point about one quarter doesn't prove a point. I think Q1 numbers will probably be quite different
Yeah.
So yeah, let's take a longer view and we'll be clearer on it.
Right, thank you.
Okay, that's probably useful because my general impression was sort of what's changed from when we last looked at it. It still looks as though Berkshire West is the sort of poor relation, and that referrals are not being converted, as it were, to eligibility. So it's almost as if we're not doing it right, or do we need more training or more staff, or you have explained, I think, the little table on, I don't know which page is which here. This is page 3. I think the one Anne Catherine McCrow is referring to, where West Berkshire has 2 in that little column, Reading 6, Wokingham 13. Wherever there are any numbers, West Berkshire is right down at the bottom. And I don't know whether that's always population size or whether there's something else going on, but maybe do we need a bigger overview of the fact that this is coming back regularly? Is it sort of, are we not getting the bigger picture? Do we need to?
I would recommend that we do keep it coming back on a regular basis. I think what's been helpful here is that there are things happening which should theoretically make the experience of West Berkshire residents more equitable and aligned to what other people are experiencing. I know it's difficult. They ask about, can we have a longer time period, is difficult if ICB colleagues have then got to go, oh God, we've got to now process all of the data and break it down and go track back and all the rest of it. But I just think unless we have a longer timeline, we will be doing this. Well, Q4 was a bit worse than Q1. What does it tell us? You know, we do need that sense of travel. And this has been, those of you that have been around a while will know that Berkshire West has, for at least 10 years, I've been here 12 years, it was one of the things that was picked up when I arrived, there was a disparity, possibly a warranted disparity, possibly an unwarranted disparity between what Berkshire West people were seeing in terms of eligibility decisions. So worth continuing to keep an eye on. Important that we take a longer view, important that we get the granular local authority level data. And if all of those things are true, we will be able to, you, the committee, will be able to express some confidence, whether it's either getting better, getting worse, or staying the same.
Okay, right. But we need to sort of like a bit more of an overview, so we've got things to compare it to in a sense, don't we? Oh, Councillor Colston.
Yes, just on the data, I think it would be helpful if the data could be normalised by population size. So what is the rate for every 100,000 people or whatever it is, so that we can compare apples with apples rather than always having, well, Berkshire West has got fewer people, so it's going to have fewer. Let's see it in a way that is directly comparable, please. That would be really helpful, I think. Thank you.
Okay. Oh, Councillor Stewart, yes?
Thank you. Yeah, CHC has always been one of those things that feels to me like it's been a little bit of a dark art, and I don't mean that in a what's the word? I don't mean that in an offensive way. It's just something that I think potentially lots of our residents are probably fairly unaware of what CHC means and their entitlement to CHC, and perhaps even some healthcare professionals. Presumably, referrals are made in good faith, and people have probably put in a lot of work and effort to put assessments together, and then they're found to be ineligible. Rather than just thinking about this as a load of numbers, and we talk about negative and positive, actually what happens to those individuals who have put forward information in the hope that they will receive CHC package in some way? What happens to those individuals when it's a negative?
It's probably, if I could pick that up, because the answer is, well, if they're not eligible for funded care from the NHS, then the likelihood is that they'll be looking to the local authority to deliver, organise the care, for which they will then be charged according to their resources.
Yeah, that's correct.
Okay, and there is the fast track, but that's for people needing end-of-life care, isn't it really? So that's...
Yes, Chair, yeah.
Yeah. Right. Have you anything you wish to add to the comments that you've heard, that you... I'm talking about our guests on the screen? No? Okay. Right. Members, any more questions, members, or comments? Thank you. I think that was a useful update. Thank you very much once again for that, and we will be seeing you again. So thank you. And I think, if possible, maybe Councillor Colston's suggestion about the population, and maybe to give us a clearer picture, so we're not having to do that sort of assessment in our own minds, that it's clearer. Is that okay?
Yeah, that's fine. Thank you.
Because obviously that you want clarifying, please come back, and I'm sure Vicky will be happy to do that. Okay. Thank you very much, and thank you everybody for your questions. Thank you.
Thank you. Bye-bye.
Bye-bye.
Right, item 9, adult social care strategy consultation. We have Paul Coe here to give us an overview of that, and members have had a chance to look at the strategy. Vicky sent us a link, so we've had a chance to have a quick look at the strategy, but please, give us your overview. Thank you.
Thank you, Chair. I'll be very succinct, if that's okay. So as you said, we have a draft strategy. We're in the consultation process. It's been published in order to collect people's thoughts. We have been out to a number of places. We're keen, obviously, to get adult social care staff's view, to get the views from partner agencies, the health system, obviously, and police and other statutory services. We've been talking to our provider independent market to say, what do you think of this? And I know that the service director who's led on this, Melanie O'Rourke's been out to groups such as the Learning Disability Partnership Board and carers groups and so on. So to really try and make sure that people know that the consultation's underway and are at least then have the opportunity to comment. So I wanted to say the same to you. You know this area really well, so you'll have a view on whether the strategy is taking the right approach. We close on the 22nd of June. If I'm perfectly honest, the best way for us to collect is through that formal online consultation process, so we can all collate it all in a coherent way. Of course, if you want to tell me things here, I will make notes and take them away. But my preference would be, if you have an interest, please let us know through the normal channel.
So go and respond to the consultation. Why shouldn't we? Yeah, I was just going to. I think you say in your sort of introduction, you want to know whether priorities are clear. Well, it seems a very clear report, and that it's important that adults with the care and support needs are met. You've got an easy reading option, which I actually quite liked. I was quite happy with easy reading options for everything, really. I wondered, obviously, a lot of the individuals needing your support will have needed that easy reading option. Are they facilitated as regards giving them? How do you get responses back from those with learning disabilities? And I know Stevenson is our rep here, so I don't know, she might have a little comment here, but I just wondered how you get those views back, because obviously they're really important, aren't they?
Can I just answer that? The Learning Disability Partnership Board had a presentation from Melanie, and there is an easy read option.
Just said. But they've got to do it online. They've got to respond online.
No, I think they had some printed copies too available.
Yeah, there have been some printed copies circulated as well. You're absolutely right, Martha. There's a whole cohort of people who would struggle to make their perspectives known, and they're the people who use our services, some of them. I think one of the things that's really important is, so let's go back to the example of the Learning Disability Partnership Board. Lots of the people in that board are family members of, carers of. You've then got, it's facilitated by an advocacy organisation. We've got, lots of organisations, carers organisations, Age UK, all of these kinds of organisations can, I think, give legitimate views on what they think would be best for the people receiving our services. So whilst we might not hear in every case the individual service user's voice, we will hear proxies and valid representatives.
So you would put quite a lot of weight on representatives from, say, representing a group.
Well,
wouldn't just.
Yeah, well, again, I mean, family members, informal carers, I think it's really important to understand, these are people, these are experts in the experience of their loved ones. And so, yeah, their view is as valid as any, I think, yeah.
You've had so far?
No, I don't. I can't speak to that at the moment, I'm afraid, no.
Yes.
I've got several questions. Sorry. Firstly, I'm very impressed with the draft strategy, but you knew there would be a but. Okay. The following bits bother me from the part on areas we need to improve upon. So I just do the easy bit first. Support people to receive direct payments to allow them to arrange their own care. And you have put down as an aim is to increase the number of people choosing direct debits to give them control. So my question is, why on earth are we at only 12% on direct payments when the England average is over double that? And is it that we don't trust people to choose wisely?
It's not an issue of trust at all. It really isn't. So it's another example of an issue that we have tried to shift and have failed. Essentially, we haven't been able to shift the dial on this, despite trying lots of different things. So just to set the context, we can arrange care for people, or we can give them the money to arrange their own care. That's what this is. This is about saying, we will give you effectively a kind of personal allowance, and you can organise your care. The principle, and the reason why I think many people think this is a good thing, is that it gives greater freedom, greater autonomy, that rather than say, well, we're going to sort it all out for you, the person gets more flexibility and freedom. It's particularly useful to working age adults with physical disabilities. That's where this has come from historically, but others might choose to use it as well. Why do we think people in West Berkshire don't take it up as much as they do in other places? Probably a couple of things. Probably, being really candid, probably our process is a bit too sticky, too complicated, too not very easy, and we've got to work on that. I also think there's something about who's doing the processing of that. So at the moment we've got a small direct payments team, and the expectation is that social workers and care management teams put the suggestion forward of, would you like a direct payment? But the experts are this other little team, and what we've tried to do is shift resource across to the direct payments team to grow it, so that if somebody says, actually, do you know what, I think I might, they can make the introduction to the specialist team quicker, rather than have to do anything as a non-specialist. There's something about I think we have to be clear. An individual using a direct payment to commission one-off care for themselves is likely to have higher costs than a local authority buying in bulk from providers. And now that there's an element of truth in that across the country. So that's not a unique West Berkshire position, but the differential the market might be such that the differential is such that people say, actually, I'd rather you do it for me because you'll get a better rate. It's worth saying it's very much swings and roundabouts, because whilst, as I say, the principle is that people get greater independence and flexibility over how they spend the money, they also get quite a lot of headaches. They've got to sort out national insurance and holiday cover and all of that other stuff, and they've got to do an awful lot of admin. Not an awful lot of admin. They've got to do some admin, which gets done by the local authority if we're commissioning. So what I should be doing on this call is selling the benefits of direct payments. What I've actually just done is say it's a bit 50-50. And if I was a disabled person, I'd have a bit of a toss-up as to whether I'd want to go down that route myself.
Thank you. The second part of the same paragraph was more people's reablement outcomes. Now, I can't figure it out. So we're 62.8% compared to England, which is 77.1. Does that mean that West Berks do not get reablement outcomes for 37.2%, or that our outcomes are less successful? Can you just answer that first, Paul?
Absolutely. So what I would want to say for context, our reablement service is exceptionally good. User satisfaction is better than anything I've seen from a private organisation. It's excellent. People love our reablement. The outcome that we want for people accessing reablement is that they do not need any care once the reablement stops. And that's not happening as frequently for us as it is for other reablement providers. And I think one of the reasons is that we're a bit more optimistic. We're a bit more okay, we're not sure you're going to be able to manage with no care, but we'll give it a crack. Whereas other providers might say, do you know what, you got no chance. You know, this is not a reablement case. So if there's a problem, it might be a degree of over-optimism in some cases, or maybe kind of slightly too inclusive in terms of who do we take forward. Now, in our strategy, what we're going to have to try and find, I think, is a healthy balance between optimism, over-optimism, pessimism. You know, we've got to walk a tight line. But that's no. I'm confident that people get a really good experience from the service, and we reable where we can.
Thank you for that. You've answered those wonderfully. I've got one final one. This is much more general. Once this new strategy is implemented, will it be advertised to ordinary residents somehow who do not, according to Health Watch, who will tell us this in a minute, I think, understand the criteria used in adult social care cases? So generally, including me, I have no idea how these cases are assessed. Will you advertise this new strategy somehow?
Thank you. Yes, I think communicating what is adult social care, what's it for, and when is it relevant is an ongoing challenge. I mean, I think we already do a fair amount of that, and will continue to do so. But the strategy is quite a useful tool in that toolbox, to say this is, you know, to give people a sense of it. Communicating to the population, as you say, plenty of people, well, many people don't think about adult social care until they're in a position where they or a loved one need it. And even then it can be hard to navigate. So we're trying to make it clearer what we do, why we do it, and how to access it in a convenient way. Yeah.
Marvellous, thank you.
Yes, I'd highlighted that one. And it might be that if we're doing some public information, or we're talking about end of life and all those things, maybe, you know, that could be some sort of package that, you know, this is what the council does. And I mean, I see posters around the town, thank you, Paul, basically trying to say, you know, this is what adult social care is about, this is the number to ring. But I don't know how you get information across. I mean, I always read posters, but everybody tells me nobody reads posters. But you need to sort of lots of different ways of trying to communicate with people. And it's really important that there's people that are missing out there, and they're probably the people that really need it, aren't they, really? So it's a difficult one, but all the practitioners need training, I suppose, don't they, in what's there. Your GP, your nurses, anybody that's coming into contact with people needs to know what's out there for them. Yeah.
I agree entirely. Actually, the last time I was in my doctor's surgery, I was really pleased to see on the notice board leaflets about what social care for and how do you access it. So, but you know, it's pretty low down the list of many people's consider it, well, you know, behind, you know, green bins and recycling centres. You know, social care is lagging behind, I'm sure. Yeah.
But it's you know, it's just so important. Yeah, I was just looking to see whether there were some points I'd made here, whether they've all been addressed. National priorities. I mean, skilled workforce you talk about. I mean, the status of those working in care still needs addressing, doesn't it? I mean, you know, and drawing people in to work in the care system. Again, we're constantly doing promotion for this as a really important profession. And it is skilled. They're extremely skilled. It's not just, you know, sort of, you know, helping somebody with simple tasks. It's really skilled, and having the knowledge of how to treat people with respect and all those things. So I think promoting that as a really important job is another issue, isn't it, really? Yes, Councillor McCrow.
Thank you. It's something I wondered exactly what it meant. It says we will adopt a waiting well approach for anyone awaiting assessment. I wondered if you could explain that, please.
Thank you, Councillor McCrow. Yeah. So the principle there is and we've all had experiences, haven't we, of waiting for something. It's about during the period of waiting, communicating so that people can, as far as possible, manage the wait successfully. So, and there'll be different elements to this, but basically, so making sure that people have got the information and advice and practical tools to cope well with whilst they wait for a full assessment. And I think sometimes in this as well, it's about giving people information about what is the wait likely to look like, so that they can plan suitably for, is this next week, is this next month? And I think part of that will be about communicating and making sure that people have the tools available to them as far as possible to manage. But what I would say, we triage everybody. We respond to the people at greatest risk very quickly. If you're waiting, it's probably because, well, it will be because somebody's made the assessment that a wait is okay, or a period of waiting is less risky than it would be for others. And so we've got to communicate during the wait. Is your situation the same as when we triaged you? Because that's the other bit, is people's circumstances do sometimes change. So yeah, so it's making the waiting act, rather than being it's just a passive, sorry, you'll have to wait and we'll get round to you. It's making sure that there is an ongoing communication process which helps people to manage that best.
Thank you.
Okay, members, any more questions? Well, thank you very much, Paul, and thank you. And we will go online and comment. Yeah, so I hope you get good responses to the consultation, and lots of useful information, and good luck with that going forward. Thank you. Now we move on to, have we got Fiona? She's still here? Okay. So we move on to item 10. Fiona Warby has been waiting patiently somewhere. Fiona is our lead officer for Healthwatch, and she will provide an update on Healthwatch's current activities, and members have received a separate report from Healthwatch about their ongoing activities. Hello, Fiona, carry on.
Hello there. Good afternoon.
Fiona, welcome.
Thank you. Would you like me to just go straight into it,
Just do an introduction or whatever. Yes, please. Yes.
Okay. Good afternoon. Sorry, can you hear me okay? I've had some issues with some being able to hear properly. Good afternoon. My name's...
Hear us? Could you not hear us, Fiona?
It was very, very quiet, so I had to put the transcript on. It's a little bit better now, but it was very, very quiet.
Oh, I'm sorry about that. What, just generally quiet, or particular individuals?
Everybody, yeah, everything was very quiet, yes.
You'll have to look into that, but we can hear you. Thank you.
Okay, brilliant, thank you.
Can you hear me?
I can hear you now, yes, thank you. Good afternoon. My name's Fiona Warby, and I'm the lead officer at Healthwatch West Berkshire. I sent through a report which I hope most of you have been able to read. If not, I will go through it quickly. We are a statutory body, so we have responsibilities to do within the area that for health and social care. And we are also monitoring what the public voice says about health and social care services. So what we've been doing this week, we've been out and about this month, visiting patients, carers, all sorts of things. And we're having a couple of events, etc., just to get out and have a chat with people about the projects that we're doing. You may or may not have heard there is a proposed abolition of Healthwatch coming up. That's in Little Lords at the moment, I believe. I think they've had the second reading this week, so we will find out what happens. Maybe the middle of June we're expecting, so probably next week we should have an update on that, really, of what's happening. but we have heard nothing at all from the government. We've had no update from them. Nothing at all from anybody actually. So we seem to get the information the same time the public does. So we will hopefully find out next week. Hopefully we do find out before you do, but who knows? We'll see. Okay, so at the moment, what we're doing is we have our annual report. So every year we have to do a statutory annual report, which has to be published by the 30th of June. So as you can imagine, it takes quite a chunk of our time to get that written. So we've been doing that since May, and we have 2 weeks left, I think, maybe just under 2.5 weeks to get the last draft in before it has to be checked. So yes, we're quite busy doing that. We have a couple of projects that we're currently looking at the moment, and we have a survey live on one of them, and the other one is just going to be coming out quite shortly. So we have some calls from residents about the patient transport that they had been using to their hospital appointments, and they were very unhappy, and we'd had quite a few calls actually, more than we kind of thought about. So we had a look at what the residents were telling us, because obviously we recorded all, and going back over it and thought, well, maybe if these people are having this problem, perhaps there's going to be others out there that are too. So we have provided a survey out. The challenge for us is actually getting it out to the residents. So we've tried to disseminate it through our social media and our website, and we've asked service partners to share it with us as well. Hannah from the carers has also shared it, which is very kind of her. So we're trying to get it out as much as possible, but it's a bit difficult. So we are putting it in the paper this week, on Thursday in the Newbury Weekly News, to see if we can maybe get those people that perhaps are not online. So some of the information that we've heard back is that the patient transport, some of it's very good and very helpful. Others, people have been forgotten about. Basically, they haven't either turned up to take them for their appointments, or they have taken them and not picked them up, or they on time, or they have just been taking them there and then they've just been left and they've had to get taxis home, even though they've booked a return journey. Also, kindness, consideration, that sort of thing has also been a bit of an issue at the moment as well. So we are just the survey is open for another couple of weeks yet, so we are waiting to hear from some more people, and then we'll go from there. The next one is our adult social care after 18 project that we're going to hopefully be looking at. So this started last year. We've been approached by a couple of people around how the young people that they still have living with them who are older than 18 are coping with life and just being out in the adult world, really. A lot of these young people have been through CAMHS, and they have come out of the other side of CAMHS and are now struggling at home with not going out, not doing anything. Some of them don't have jobs. Some of them are living their lives in their bedrooms and not having any social life or anything at all. And the parents have kind of got to the point where, what do we do? Where do we go? And we've kind of looked at that. But also it's about how the experiences are for both the young people when they come through into adulthood, and also the people who look after them, whether they might be the parent carers or a social worker or a service provider. It's how they feel that they're getting help or not, or whatever. So that's coming out soon. It's been in the works for quite a while because we wanted to get it as right as possible, really. So yeah, that's that one. And the last thing, well, it's not last, we've got lots of other things, but what we're concentrating on at the moment around our annual report is also women's health. So we had, it's been going on with women's health in West Berkshire quite a long time now. It started in 2023. We had several conversations with the at the time Bob ICB about it. There was money given from the NHS, which things didn't happen as they were supposed to happen. And then we kind of brought it back up again. And from there, the ICB said that a women's health strategy would be in the works. We had a draft one sent out because women's health in West Berkshire is nothing. We have none. In Oxfordshire, Buckinghamshire, they have women's health hubs. They have lots and lots of support for women, but in West Berkshire, unless it's private, we don't really have that. You can go to your doctor, of course, and go through the normal things, but actually a specific women's health hub we do not have. So the strategy that was supposed to be happening has been put on hold at the moment. My understanding is we did request an update from Thames Valley probably January, and we were asked to wait because obviously changes were happening. So I am going to go back and request an update again about this strategy because the draft came out and needed some work, quite a bit of work doing to it before it could go any further, really. So that's where we are with our projects. We do have emerging themes that we listen to from residents that contact us, and every month I do a quick scan through all of the records that we've had just to see what the themes are coming out. So this quarter, it's been access to services. The residents are continuing to report challenges navigating health and care services, particularly where multiple organisations are involved. Communication and information. Clear information is remaining a priority. Residents are frequently highlighting difficulties understanding service pathways and available support around these. We have had some comments on adult social care awareness. Residents are asking for a need to improve public understanding of adult social care. And within that, can't say the word. No, I'm not going to try it again because I just know I'm going to get it wrong. No. If you've got the report, you can, somebody might be able to help me out with this word. I just can't say it today. Assessments and funding arrangements. There's been quite a lot of queries around that. And we're basically obviously going out into the diverse communities to try and speak to people who we can, who perhaps don't often get heard. It is a challenge. A lot of these communities don't want to be involved or talk to anybody. So we do keep knocking on the door, and we will keep knocking on the door whilst we're here. So yes, that's it from us, really. Thank you.
Thank you very much, Fiona. Yes, good to see you. Good to have you at our meeting.
And you, thank you, Chair.
We've had your report, but I don't think we've seen you on the screen for a bit. So yeah, I mean, each time, you know, you send a report, the Health Watch is always on our meetings, and we always comment on the value of what you do and the concern about the plans for the abolition, is the word, of Health Watch. Stephanie and I have taken that to the Joint Health Area and Scrutiny Committee, and it's been brought up the last 2 times, you know, since this stopped being talked about, and universally everybody is extremely concerned, and we do have senior people in health at our meetings so they can hear these concerns. I thought there was some sort of on hold because the whole idea of scrutinising, you know, the ICB within the ICB just doesn't make sense. So I think there's an awful lot of lobbying going on saying that this is, so hopefully the House of Lords, who often speak a lot of sense, might come out in support of what's going on here. So, I mean, as usual, the projects that you're bringing up are really important and crucial. And hopefully you're aware that we are scrutinising women's health at our September meeting. It should have been at this meeting, but we had a delay in getting a report through. And we're very aware that we have no women's health hub. And women's health issues are becoming much more, you know, you're hearing a lot in the media about specific women's health issues and the lack of understanding about them, which is where the hub is so important. So that's will be coming up to our next meeting. The emergency transport, I think, is on next March's agenda. I don't think we can deal with it before then, but that again is something that you've highlighted, and we will be discussing that. And you hopefully be aware that there's consultation going on at the moment into adult social care.
Yes.
And going forward. So the issues you've raised here are very much, some of them, relevant to that consultation. So hopefully, you know, when people approach you, you know, they will be forwarded on to sort of put their comments onto the adult social care consultation, because it's all really, really very important to get those on board. So thank you so much for the work that you're doing.
Thank you.
Any members got any thoughts? Yes, Councillor Marsh.
Chair, if you just allow me to say this, I don't know whether it's a laugh or cry, but just to reiterate the point you've made about Health Watch, I've just been looking at the government's reasons for abolishing it, and what they say is, it's straight out of Sir Humphrey. Fewer organisations in the patient safety landscape will mean that patients, staff and users will have a clearer path to sharing their views. So you're abolishing a way in which...
Ms. Fiona, can you hear Councillor Marsh?
They're abolishing a way that you can share your views because they say it will make it a clearer path to sharing your views. It's just complete rubbish. Obviously, all the political parties represented by members of this body in Parliament have been opposing this. But I suspect that the government isn't listening. They seem determined to do it. But hopefully, as you suggest, there may be it may get defeated.
Yes, Councillor Marsh, and earlier during the year, actually during the sort of December, January time, we were asked by the MP Lee Dillon to help look at pathways to health and social care, as his team were being contacted by the community quite a lot, and they weren't quite sure on where to signpost and to who. So we did a mapping exercise, and we found over 157 pathways to feedback within health and social care in West Berkshire alone. Some of them are national, you know, not many. So if you know, when we counted them all up, we were absolutely astounded to see this many. What can, you know, so we've kind of put that back to the ICB to say, perhaps, you know, going forward, you need to kind of streamline them a little bit, perhaps. So it's a wait and see thing, I think. You know, with my concern is the independent voice is not going to be around if Health Watch go. And obviously we have statutory obligations, and we do have that power that we can take services to account, but I think, you know, that isn't used very often. I don't really feel that we need to use that very often. Sometimes just a good conversation can resolve most issues. But yes, I think that is the main worry now. And I think looking at what was said in Parliament on Tuesday last week, there was some confusion about why this was being done, and perhaps that that this needs to be looked at a lot deeper than it was originally. You know, the thought was given that it was just like, oh yes, let's do this from Dr. Penny Dash's report. So we'll wait and see.
Okay, right. So it's not a done deal yet. So we're still
no.
Hope. So still worth lobbying and get the issue out there, and
yes.
You know, make sure people.
Yeah. So Health Watch is by the time, you know, at the moment we are looking at it. We will probably still be here for about a year, by the time, because it has to go through Parliament and it has to be gone through law, and they have to officially abolish Health Watch. And obviously, you know, they're going to be going on their summer recess soon. These things don't move very quickly. So we are looking at mid 2027 by the time that gets sorted out, assuming that the abolition still goes ahead.
Right, okay. Right, well, we're very much sort of in support of Health Watch, obviously. And as you said, the independent voice has got to be there. It makes it's really, would be desperate if we lose that. So thank you for your report, Fiona.
Thank you.
We'll be seeing you again. Yes.
You will, yes. Thank you.
Thank you very much. And thank you for waiting. Thank you.
Bye-bye.
Okay, members, item 11, which is on page 69, I think, or it's my 69, is to review the draft work programme for 26-27 and to propose any additions or changes. And as you know, all proposals are put through the prioritisation tool and are considered by Chairman and Vice Chairman ahead of the next meeting. So we actually have a tool which Vicky, I think, has given details of in the past when things are proposed, but we're always looking for proposals from members and from members of the public out there for things that we should be scrutinising. But you'll see what's coming forward, and we've got quite a full agenda in September, which includes the Women's Health Strategy, Carer Strategy, Better Care Fund. So there's quite a lot of items on there. As I said, we should have had the Women's Health Strategy at this meeting. Yes, Councillor Stevenson.
Only that, Chair, earlier I asked if we could bring back palliative care once the partnership has done its course. So I was hoping for March 27, but you've already got quite a few things there. I don't know if the inquest review panel is quite a short item. So if we can fit in revisiting the new way of working palliative care and hospice provision in March, that would be lovely. Thank you.
And would we want to include children's?
Yes, you mentioned that earlier. Yes,
because
yes.
that would make it a more substantial item. But we'll consider that. Hopefully, we could maybe squeeze that in. And we have got an extension to 4:30, so we've got a little bit longer than we used to have. Oh yes, Councillor Stewart.
Thank you, Chairman. With the horrible situations that have arisen in this area regarding meningitis, I'm quite interested in the vaccination programme, and certainly there have been a number of petitions, I think, that have been set up to look at extending or certainly catching up some of our young people who will not have been vaccinated. And I just wonder whether we might at some point on this committee consider talking about vaccinations. And it might not be just meningitis, it could be others. I know that I think in the past we've had a really pretty good uptake for measles, but sometimes the second vaccination is not as high an uptake. So yes, that was my suggestion, and I don't know where you would fit it in amongst all of this, but perhaps put it in the tool and see what it says.
Well, that's important. Yes, all immunisations, particularly the ones you've just highlighted there. Thank you. We'll look into that one. Thank you. Thank you, Councillor Stewart. Any more comments from anybody? No. Well, thank you, everybody. Thank you for attending, and thank you for all your questions and comments. I think it's been a really useful meeting. And thank you. Thank you very much. Goodbye, everybody.